Okay, welcome to the next module. This is Dr. K or Dr. Greg speaking, and we're going to talk about upper and lower respiratory disorders. So, at the beginning of this module, I'm going to spend some time briefly just talking about the disorders, and then we're going to go into them in more depth later on. Okay, so if you would rather just go to the in-depth topic, then skip the slides that have the list of topics on them. But I think they're worthwhile listening to because they just give you a general overview and a feel for the different conditions. Okay, so let's get started. Now this is chapters 20 to 26, so there's quite a lot of information. I'm trying to keep these to 3.5 to 4 hours, so hopefully this one stays at that length of time. Okay, so here's the first slide on some topics that we're going to discuss. Some of these we're not going to go into as much as other topics. Okay, so let's start, and it's good to just recognize the different diagnoses and the different terms and what they mean. Okay, so let's start at the top. What's rhinitis? Rhinitis is just another term for inflammation of the nasal mucosa. Okay, so what can it be from? Well, typically it's from either a viral infection or it can be from allergic conditions that when the person inhales the pollen or the allergen, they have congestion of the nasal mucosa, and typically they'll have a runny nose, sneezing, and sometimes rhinitis, whether it's from a virus or from an allergy, can block the pores, or what are called the ostia, the holes that allow the sinuses to drain. So you can get a secondary sinusitis because of all the inflammation that's taking place within the nose. Okay. So if it's an infectious rhinitis, typically from a virus, well, it's really just symptomatic treatment, right? We can use short-term decongestants such as phenylephrine. They're typically over the counter and they just run their course, right? They're not typically a bacterial infection. Okay. All right, what's sinusitis? Well, sinusitis is inflammation and infection of the sinuses of the face. So we have frontal sinuses, which are above your eyes. We have maxillary sinuses, which are basically in your cheeks. We have ethmoid sinuses, which are basically behind your upper nose. And these sinuses can get infected, right? And most of them we know now are, again, from viruses. You can rarely develop a bacterial infection of the sinuses. And if it's a bacterial sinusitis, then we'll treat those with antibiotics. Okay. What are the symptoms of a sinusitis? It's usually localized pain over the sinus that's infected. So it might be facial pain or pain over your eye, your eyebrow area, purulent nasal discharge, sometimes bloody nasal discharge. You often have nasal congestion with it. Okay. Laryngitis is inflammation and sometimes infection of the vocal cords. So if it's an infection of the vocal cords, it's typically viral. Okay. So what can we do for this? Well, typically we just tell the people to rest their voice, increase fluid intake to keep the vocal cords lubricated, and most of the time it just settles by itself. Okay. So again, laryngitis can be a viral laryngitis, or it can be from overuse of the voice, right, where you've irritated the vocal cords. And what do you do for that? Voice rest, right? Sometimes we'll use anti-inflammatories for any of these conditions, whether it's rhinitis, sinusitis, or laryngitis. Okay. What's pneumonia? So pneumonia is an infection of the lung. And more specifically, it's an infection of the alveoli of the lung. So the alveoli fill with pus and fluid, and you can have bacterial pneumonias, you can have viral pneumonias, those two are by far the most common. You can have fungal pneumonias of the lung, which are much less common. They would typically be in immunocompromised patients more often. And we'll get into that in more detail. Influenza, a viral infection, right? And we'll talk about influenza in more detail. So it's a respiratory condition where you develop a viral infection, and typically it's like a really, really, really bad cold. So cough, fevers, but now you have sore muscles, myalgias, you have aches all over your body. You've lost your appetite, you feel weak. And a complication of influenza, and one of the deadly complications, is developing a influenza pneumonia. Okay? What's ARDS? Acute respiratory distress syndrome. So this condition is typically caused by any severe illness that's occurring in the body. Okay, so it doesn't necessarily have to start in the lungs. And what happens is the blood vessels within the lungs become leaky and vasodilated, and they leak fluid into the interstitial space all around the alveoli, and that leads to very stiff lungs because they're filled with fluid, right? So it makes it hard for the person to breathe. They can't expand their lungs because they're so stiff and filled with fluid. So some patients with ARDS, they can't maintain their oxygen levels in their blood, and this can lead to the need for intubation and ventilation. Okay, let me give you an example. Someone develops severe pancreatitis. Okay, well, with severe pancreatitis, you can have diffuse inflammation throughout the body. That causes the blood vessels in the lungs to be leaky and lead to ARDS. Okay, another example, burns. Somebody has a severe burn, which causes tremendous inflammation. The inflammation travels through the bloodstream, and in the lungs it causes vasodilation and leaky blood vessels, causing ARDS. So ARDS can be a complication of other diseases. Okay. Another example, someone's in a car accident and they have a massive force hit their chest, such as a steering wheel, because they weren't wearing a seatbelt. Well, they're going to get bruised lungs. We call that a pulmonary contusion. But they can also develop secondary ARDS because there's inflammation, and that can result in a lot of fluid leaking out of the pulmonary vessels, causing stiff lungs, ARDS. Okay. What's asthma? Asthma is a recurrent condition through life of airway bronchoconstriction and airway inflammation. And we'll talk much more about asthma. But remember those two components of asthma: bronchoconstriction, airway inflammation, causing excessive mucus production. And it's recurrent, meaning in between the episodes, the patient may be just fine with very little symptoms. Patients with asthma often need bronchodilators and anti-inflammatory medications to control their asthma so that they don't get frequent flare-ups. COPD, so chronic obstructive pulmonary disease, is a disease typically from smoking. That's the number one cause. And there's two components to it. There's chronic bronchitis, which is uh, damage to the bronchial tubes that leads to excessive mucus production. So they're coughing up phlegm chronically. That's the first part. The second part is emphysema, which is destruction and inflammation of the alveoli. Okay, and that's going to lead to decreased ability for oxygen to cross over the alveoli to the bloodstream, and also difficulty for CO2 to get into the alveoli to be exhaled. Okay, so think of COPD as those two conditions combined: chronic bronchitis and emphysema. What's tuberculosis? It's an infection of the lung typically. So pulmonary tuberculosis is the most common form of tuberculosis. It can also affect lymph nodes in the body. It can affect organs of the body. You can get tuberculosis of your kidneys, of your adrenal glands. Okay, but by far the most common is pulmonary tuberculosis, and it's caused by mycobacteria. Okay, and we'll talk much more about tuberculosis. Okay, what's Legionnaire's disease? This is a type of pneumonia, Legionnaire's pneumonia, and it's caused by a bacteria. Okay, so Legionella pneumonia is the bacteria that causes this disease, and typically people get it from soil or water. There's often outbreaks of Legionella, say in buildings where the air conditioners haven't been working well, and the water in the air conditioner is growing Legionella, and the fan of the air conditioner is throwing out the bacteria into the air that people inhale. Okay, so we often hear of outbreaks of Legionnaire's disease. So if I think of Legionnaire's disease, I typically think of inhaling the bacteria from some kind of water source that's contaminated, whether it's a shower, a hot tub, a ventilation system with air conditioning, anything where there's water that's vaporizing into the air. Okay, what's a pulmonary embolism? Well, a pulmonary embolism is a clot of blood that's typically traveled from a deep vein thrombosis in a leg or pelvic veins, broken off, traveled to the heart. Okay, it landed into the right atrium and then the right ventricle, and then got pumped to the pulmonary system through the pulmonary artery, and it lodged into a segment of a pulmonary artery or pulmonary vessel, causing blockage of that artery. Okay, so what's going to happen? Well, that part of the lung could die, okay, potentially because of loss of blood supply. That part of the lung is not going to receive any blood flow. Okay, so there's going to be, so a pulmonary embolus is a perfusion problem, lack of blood flow to a certain part of the lung. Okay, what symptoms do people usually develop with pulmonary embolism? They usually come in and say, I had the sudden onset of shortness of breath, I coughed up some blood maybe, and I have pleuritic chest pain. When I take a deep breath, my chest hurts in a certain area. Okay, so why is that the case? Well, every time you take a deep breath, you're stretching that pleura, and with a pulmonary embolism, you've blocked an artery to a segment of the lung, and that segment of the lung is touching the pleura, and it's inflamed now. So when you take a deep breath, you get pleuritic chest pain. Okay, so when we hear someone has pleuritic chest pain, we think of a pulmonary embolism to rule out. Okay, what's sarcoidosis? This is a strange condition. It's an inflammatory condition of the lung where you form what are called granulomas, which are just collections, basically lumps of um, inflammatory cells that we see on chest x-ray. Okay. What are symptoms of sarcoidosis? Well, it can be anything, any respiratory type symptoms, because you're forming these inflammatory granulomas throughout the lungs. So you could have coughing, wheezing, shortness of breath, and we'll often diagnose it on a chest X-ray, a CAT scan, or sometimes even a lung biopsy. Okay, so it's not an infectious disorder. Rib fractures. Well, rib fractures are usually from trauma or a fall or a car accident or a motorcycle accident or falling off the roof. And it really just depends on how many ribs have been broken. If you have one rib fracture, um, with pain medication such as non-steroidal anti-inflammatories and maybe an opioid analgesic such as morphine, um, and we give someone a incentive spirometer to take nice deep breaths to avoid atelectasis of the lungs, they usually do fine. The ribs will heal in 4 to 6 weeks. If someone has multiple rib fractures, say 4 or 5 or 6 rib fractures on one side, say from a motorcycle accident, they may not be able to breathe on their own because there's severe pain. Okay, so they may require oxygenation, or an oxygen supply. They'll need significant analgesics, typically opioids, to control the pain. Sometimes patients with rib fractures will get a nerve block in their back to block the pain signals that are coming into the spinal cord from the fractures, so they can breathe better. Okay. A flailed chest. Well, we're still on rib fractures here. So a flailed chest is where you have basically a loose segment of ribs from an injury, typically. So it's usually 2 rib fractures involving 2 or more ribs. So now what you have is you have a segment that's loose in the chest wall, right? Because each rib has 2 fractures and it involves 2 or more ribs. So if you were to touch that segment with your hand, it would actually go in and out. Okay, you'd be able to press that segment in and out. So, for example, when they take a big breath in, that segment goes inwards. Okay, because when you take a deep breath, you have negative pressure in your chest, and that flailed chest isn't going to follow the normal expansion of the chest, so it's going to go inwards. Okay, called paradoxical breathing. Okay, so sometimes a patient with a small flailed chest, okay, well, they don't need to be intubated. We're going to give them pain medication, oxygen, and they'll be able to maintain ventilation. A patient with a large flailed chest, so a large segment, is loose. So when they take a big breath, well, that part goes inward, so they're not able to maintain oxygenation because they're not expanding that lung very well. And those patients may have hypoxemia, low O2 saturations, and they may need to be intubated because they can't maintain oxygenation. Okay? They're not able to ventilate properly because of that loose, large chest segment. What's a pulmonary contusion? A bruised lung, right? So usually from an injury or a fall, and you had a significant impact to the chest, which bruised the underlying lung. Now, if you have significant pulmonary contusions, that's going to make it hard to breathe. So if you fall off a 20-foot roof and land on your chest or your back, and you have pulmonary contusions that we can see on chest x-ray, well, that's basically fluid and blood that's leaked all into the lung. That's going to make a stiff lung. It's going to make it really hard to take a deep breath. So someone who has severe pulmonary contusions, may have to be intubated, right? Because they can't ventilate because the lungs are so stiff. A pneumothorax is a collapsed lung. If it's a simple pneumothorax, it just means that the lung has separated from the pleura and it's collapsed. So it's not being expanded with inspiration. A tension pneumothorax is when a simple pneumothorax now builds up pressure in the pleural space. That's much more severe. Okay, so a simple pneumothorax, someone might come in and say, well, I have chest pain on the side of the pneumothorax. I'm a bit short of breath, having difficulty breathing because of the pain. A tension pneumothorax, they're going to be much sicker because the pressure in the chest is moving all the contents of that side to the other side of the chest. Okay, so they're going to be acutely short of breath. They're going to be hypotensive because there's no blood coming back to the chest cavity because of all the pressure. So there's no blood coming back to the right atrium in the right ventricle. So they're going to have hyperresonant lung sounds on the side of the chest, just like a simple pneumothorax. They're going to be tachycardic, hypotensive, distended neck veins, tracheal deviation to the other side because of the pressures pushing everything to the other side. Okay, so distinguish a simple pneumothorax from a tension pneumothorax. Okay. A hemothorax is blood in the pleural fluid, blood in the pleural space. And that's typically from trauma. So you had a significant chest injury and the blood vessels in the pleura bled, or say you lacerated one of the lungs and it bled into the pleural space, and you have a hemothorax. Okay, a small hemothorax we may just ignore and just follow it. A significant hemothorax, we're going to put a chest tube in and drain it because that blood is stopping the lung from expanding. Okay, empyema is pus in the pleural space. And where does it usually come from? It usually comes from a pneumonia that started next to the pleura, and then the pneumonia infected the pleural space and caused pus collections called empyema. A pleural effusion is a collection of fluid in the pleural space. It can happen from congestive heart failure, where there's lots of fluid within the lung tissue and it starts to leak into the pleural space. Okay. So I hope that helps. I know I used 22 minutes, but I hope that helps. Okay, let's just continue with an overview of topics. Okay, so here we'll go through this slide and then we'll start. So aerochambers, well, an aerochamber is just to help patients get the medication of an inhaler into their lungs. Okay, and so we use metered dose inhalers of different medications. We attach the metered dose inhaler to the end of it, and the chamber is put then to the mouth. And when the MDI is squeezed, it puts the medication into the air chamber to then be inhaled. So how does that help? Well, the patient doesn't have to time the sequence of when they press the MDI and when they inhale. Okay, because that can be really difficult for patients. So it just allows more of the medication to be deposited into the lungs. Okay, a nebulizer is where we'll put liquid forms of medications such as albuterol or ipratropium into a nebulizer, and then we'll run oxygen through the nebulizer, and then with a face mask or some kind of mouth attachment, it'll be misted and they'll inhale the medication. Okay. There's also dry powder inhalers. So instead of MDIs, which are basically puffers, there's dry powder inhalers where you just twist the inhaler, and then there's a powder sitting in there that the person puts to their mouth and just inhales it. Okay, so they're also available. So for example, you wouldn't need an aero chamber with a dry powder inhaler. Okay, let's just talk about some medications. So medications for bronchodilation. So whether it's for asthma or COPD or someone that's just wheezing and we have no idea why, well, we can use bronchodilators, such as a beta-2 agonist. Typically, albuterol is a common one. Okay. There's also bronchodilators in the anticholinergic group. So they work by blocking this parasympathetic system to the lungs and allows for some bronchodilation. So beta-2 agonists and anticholinergic inhalers are bronchodilators. Methylxanthines, well, that's theophylline or some kind of variant of theophylline, and that's usually in a pill form or IV. We don't use theophylline very much anymore. It's like a coffee derivative, so it has a lot of the side effects of coffee: anxiety, jitteriness, tachycardia. It has a bit of diuretic effects, so patients urinate more. And it has very weak bronchodilator effects. Plus, theophylline has a lot of drug interactions with other medications patients are taking. Okay, so I think you'll have to know theophylline, but just know that we just don't use it very much anymore. It's not highly effective, and it has loads of drug interactions. Okay. A SABA, what's a SABA? A short-acting beta agonist. That's albuterol. Okay, so you're short of breath right now, you're wheezing, you can take inhalations of a short-acting beta agonist such as albuterol. So that's a rescue medication. Okay, people carry it in their pocket all the time for when they're short of breath. A long-acting beta agonist. So they've just taken a beta agonist and they've put it in a long-acting formula or molecule, and we call it a long-acting beta agonist. Salmeterol, okay, is a common one. What does that do? Well, compared to albuterol, which just bronchodilates for a few hours, salmeterol can be used for control throughout the whole day because it is bronchodilating for much longer. It's not used as a rescue medication. Okay, it's used for daily control of the asthma, but not the rescue. The only rescue is the short-acting beta agonist. Okay, glucocorticoids. Well, inhalers are probably the most common way of delivering glucocorticoids to the lungs because it's safe, and we can deliver the glucocorticoid through the inhaler to control inflammation. So that's what glucocorticoids do. They're anti-inflammatories. So we use them in asthma for long-term control. We use them in COPD to decrease the inflammation. In patients that are controlled on an inhaler form of glucocorticoids, we don't need to use oral or IV glucocorticoids. If they come in with a flare-up of COPD or asthma, and their inhalers aren't working, then we can introduce an oral glucocorticoid or an IV glucocorticoid, such as methylprednisolone. The oral one we typically use is prednisone. Okay. One thing to remember about an inhaler of glucocorticoids is you need to rinse your mouth out afterwards because of the risk of developing thrush in your throat. Okay. The other inhalers don't do that, but because glucocorticoids are immunosuppressants, they can cause local development of candidiasis, which we call thrush in the throat, okay, in the mouth. Okay, antibiotics. Well, what do we use antibiotics for? Well, typically pneumonia and a flare-up of COPD. We can also use it for a bacterial sinusitis. But remember, most of the conditions that we spoke about in the upper respiratory tract are viral. So laryngitis, rhinitis, and most of the sinusitis are viral. But if we think the sinusitis is bacterial, then we can use an antibiotic. Okay. In pneumonia, well, the most common cause of pneumonia is viral or bacterial. We typically can't figure out which one it is, so we always use antibiotics in pneumonias, since we can't be sure it's not a bacterial pneumonia. In patients with COPD that have a flare-up where they're coughing more, they're short of breath, they're coughing up purulent phlegm, we start them on an antibiotic, and we also often start them on a glucocorticoid orally, such as prednisone, to reduce the inflammation. You don't need antibiotics in an asthma flare-up, okay? You just need bronchodilators, such as albuterol, an anticholinergic, such as ipratropium, to bronchodilate, and a glucocorticoid, whether it's an inhaler or an oral or IV. It just depends on the severity of the asthma flare-up. Monoclonal antibodies have come out for many conditions. Oh, let's just talk about leukotriene inhibitors. Sorry. So montelukast, it's not used very commonly anymore, but we thought it would be very effective because it inhibits leukotrienes, which are part of the inflammatory system. So we thought, fantastic, this is going to work for asthma, allergic rhinitis, all kinds of allergy-related conditions. We can still use it for someone with asthma. It's not very effective, so you won't see it very commonly. Okay? We can still use it for someone who has allergic rhinitis, but we typically use nasal steroids in the form of nasal sprays, right? So it's just not a common medication you see very often because the glucocorticoids are much more effective for the inflammation. Monoclonal antibodies, so these have come out for all kinds of diseases. So this particular one, they're all impossible to pronounce. So omalizumab, they all end in MAB usually, and these in this case used for asthma to stop some of the inflammatory process. This monoclonal antibody, that's how it works. So it's kind of a last ditch effort. These are very expensive, and most people are controlled with their beta agonist, their anticholinergic inhalers, and their steroid inhalers, such as fluticasone. Okay, the majority of people. Antihistamines are typically used for allergies, so whether it's an allergic skin condition such as urticaria, or allergic rhinitis, or allergic conjunctivitis, which is allergies in the eye, and they just block the effects of histamine on the receptor cells. Okay? Nasal decongestants such as phenylephrine, so these can be bought as a spray or pill, tablet form, and they vasoconstrict the blood vessels in the nose, allowing people to breathe better. Okay? Now, because they're stimulants, so phenylephrine or neosynephrine, they're all stimulants. They're alpha-1 agonists, so they stimulate the sympathetic system. Okay? So if you're taking this as a spray, well, that's fine, but you just can't do it for more than 4 or 5 days because when you stop it, you're going to get rebound nasal congestion. If you take it as a pill form, well, you are stimulating the sympathetic system because this is a chemical that stimulates the sympathetic system. So you may get hypertension. You may get tachycardia. It might aggravate glaucoma. So on those packages, you'll see when you're buying nasal decongestants orally, it's going to say do not take with hypertension, don't take with angina or chest pain conditions or cardiac conditions. because it's going to raise blood pressure and also raise heart rate. What's an expectorant? An expectorant is just, they don't work very well, by the way, so I don't advise patients to buy them. What are they supposed to do? They're supposed to just loosen the phlegm and the mucus off the bronchial walls. That's all they do. That doesn't make any sense. How can the medication you take orally somehow get into your bloodstream and loosen sputum on bronchial walls? So most of us don't prescribe them very often. I know they're very popular over the counter. Honey works best in any of them. But that's the mechanism, the supposed mechanism of action, loosening the mucus off the bronchial walls. What's a mucolytic, such as acetylcysteine? That's a medication that actually tries to break down the thick mucus. So patients with COPD or cystic fibrosis that have really thick, tenacious sputum that they can't cough up, sometimes we'll use acetylcysteine nebulized to get into the lungs and try and break up this thick mucus. Okay. Antitussive, what's that? It's a cough, just to stop a cough. So tussive is cough, antitussive is anti-cough. Are they very effective? No, not really. Dextromethorphan is a common one. It's a variant of an opioid. Honey is shown to be more effective as a cough suppressant. Okay, so a lot of them you'll see are honey flavored or honey added, and that's just to try and sell them. Tuberculosis medications we'll talk to in more detail. So there's a medication called isoniazid for latent TB, meaning someone tests positive on a TB skin test, but they don't have active TB. They don't have any symptoms. So, but it's to try and clear this latent TB that they acquired from somewhere that may be activated later in life. Okay, and then there's tuberculosis medications that we use typically in combination to try and treat active TB in the lungs. And it usually takes 3, 4 different medications combined to treat tuberculosis for a prolonged period of time. Okay, so it's typically taking these medications for 9 to 12 months, sometimes up to 2 years to try and get rid of tuberculosis. Influenza medications, we're going to talk briefly about amantadine. Another one that you might recognize is Tamiflu, which is oseltamivir. They need to be taken early on in the influenza condition. And again, they're not very effective for influenza. So typically they're taken in the first 24 to 48 hours. Well, how many patients know they have influenza in the first 24 to 48 hours of having symptoms? Not many. And on top of that, many of the medications have side effects, and they've really only been shown to reduce the illness by 6 to 12 hours. So not very effective. Many places have stopped using them because the evidence is very weak for their efficacy. Okay, we'll move on. Okay, so what about these precautions in terms of not spreading an infectious disease? Well, there's contact precautions, and that's typically for, say, an infectious rash. Say someone has impetigo, right, which is a superficial infection of the skin. Well, that's going to be contact precautions. MRSA can also cause infectious skin symptoms. So a MRSA infection or a MRSA abscess, so methicillin-resistant Staph aureus, that would be contact precautions. You wouldn't want to directly touch the rash of MRSA, right? Diarrheal illnesses are contact precautions. Open wounds. So open wounds, again, would be contact. How are you going to spread it? By touching it, or a healthcare worker touching it and then touching something else, right? So that would be contact precautions. So hand hygiene, wearing gloves, gowns to avoid transmitting the disease. Droplet precautions are from typically respiratory conditions, right? So droplets typically don't travel too far. They travel a meter or two and then they drop because they're in larger droplets. So colds, diphtheria. So most of us are immunized against diphtheria, which is a infection of the back of your throat with a bacteria. Won't see it very often because most of us are immunized. Influenza is droplet precautions. The plague you're not going to see very often. That's caused by a bacteria called Yersinia, but not common at all. Strep throat, that'll be droplet. Meningitis can be droplet because often they have the infection within their lungs as well. Meningitis is an infection of the linings of around the brain, the meninges, but often they have respiratory symptoms as well. Mumps is infection and inflammation of the parotid salivary glands. Okay, so swollen salivary glands on each side. So they have a really swollen face. Mumps can often affect can lead to sterility because it inflames the ovaries or the testicles and can lead to infertility and sterility. Pertussis is whooping cough, another droplet transmitted disease. RSV, respiratory syncytial virus, is common in children and can easily be spread through droplets. Okay, so just know your airborne precautions. So hand hygiene for sure, because you could have acquired the droplets on your hands, and wearing a mask. Okay. Airborne just means that the infection has the ability to travel further in the air. That's it. It can go further than droplets. Okay, so you could actually think of airborne as tiny little droplets that have gone further. I don't like this distinction, but it exists. Okay, so here's some examples of airborne precautions. So tuberculosis, chickenpox, because chickenpox isn't necessarily just on the skin. It can actually be a respiratory illness as well. Measles, I know you have a rash with measles, but you have a respiratory condition with it as well. Okay, so droplet precautions, you can see there's more: hand hygiene, surgical mask, gloves, gown. Okay. Okay, so I think these slides will go much faster because we've spent some time already talking about these conditions. So laryngitis, we won't spend much time on. It's inflammation of the larynx and the vocal cords. People typically have decreased ability to talk, a very hoarse voice, maybe some throat pain with it. And typically it's from a virus from overuse of your voice, and it's voice rest and lots of fluids to keep the vocal cords hydrated. Okay. Influenza, we're gonna talk about coming up soon. There's two forms. There's seasonal influenza, which is what we typically deal with. So in the fall and winter months is when influenza typically comes through. Why? People are close together in the winter months, right? They're aggregated together typically, especially in colder climates. Or you can have a pandemic of influenza where it just spreads across the world. Okay. We typically know which strains, or we try to predict which strains are coming through for the upcoming year, because we can look at other countries that went through their winter. So Australia and other countries, we can see which strains went through there, and we can try and predict which influenza viral strains are coming through for the upcoming winter. Okay. Pneumonia, we're going to talk about. Sure, they can be classified into two groups. Community-acquired pneumonia, meaning you got it somewhere in the community, at home, at school, wherever. outside of the hospital, and healthcare associated pneumonia, meaning you acquired the pneumonia after admission to hospital. So you got it within the hospital setting. And one of those examples of healthcare associated pneumonia would be ventilator associated pneumonia. So after being intubated and put on a ventilator, one of the complications is developing a pneumonia, right? You have a foreign tube in your trachea that's breathing for you. And that's a risk factor for developing ventilator-associated pneumonia. Oh, okay, well here's laryngitis again, so we'll talk about it in a bit more detail. So laryngitis, most of them are acute laryngitis, and most of those are caused by a virus. Okay, so someone comes in and they can't speak and they have a hoarse voice, that's typically from a virus, very rarely from a bacteria. Okay. So we don't use antibiotics typically for it. What are some other causes of laryngitis? Well, GERD, so you're refluxing acid, typically while you're sleeping, up to your vocal cords. And then the acid touches the vocal cords and gives you a hoarse voice. Okay, so GERD can actually cause laryngitis. Overuse, so you go to a concert, you're screaming like everyone else at the concert, and the next day you have laryngitis. Okay. So what are the expected findings? A hoarse voice, or aphonia even, meaning I can't talk at all. Some people can just have a simple mild tickle in their throat, but usually if it's affecting the vocal cords, it's going to be hoarseness, and if it's really severe, aphonia. Okay. What medications do we use? Not many usually, because the vast majority are not bacterial, they're viral. Could we use corticosteroids to treat this? Well, if someone has ongoing inflammation of the vocal cords and their voice just isn't coming back and they're hoarse all the time, we could try corticosteroids to try and reduce the inflammation. So, sure. Remember, most viral laryngitis will just resolve on their own with fluids and voice rest. Okay. What else can you do? So I mentioned voice rest, mentioned fluids, humidifying the air, so putting a humidifier in the room that the patient sleeps in. Advising them to stop smoking because smoking irritates the larynx and the vocal cords. Okay. And of course, laryngitis is made worse by cold air. So when you're breathing and cold air hits this irritated vocal cords, it causes people to cough and because of the irritated vocal cords. Okay, so what about influenza, or what we call the flu? So when somebody comes in and says, I have the flu, most of the time what they mean is, I have a cold. Because the majority of people that have cold symptoms, cough, bit of sputum, achy joints, it's typically a viral infection, such as an acute bronchitis. Okay, but patients that come in that are significantly ill with really severe muscle aches, weakness, coughing, shortness of breath, then we may consider testing for influenza. Okay, not that there's much we can do about it because the antiviral medications aren't very effective. Okay, so very common in the fall and winter months. So we're looking at September until April. Very contagious. Okay, so typically a day before getting any symptoms at all, so that's the incubation time or the incubation period where the person has no symptoms, and typically 4 or 5 days after they have symptoms, they're contagious. And as I mentioned, these patients are miserable. Severe headaches, muscle aches, weakness, fatigue, fever, and they can be hypoxic. Why? Because influenza, one of the complications of influenza is influenza pneumonia. And when it attacks the lungs, or it gets down as low as the lungs, it can cause problems with oxygenation. And that's why some people die of influenza, because they get pneumonia and they end up on a ventilator or they just die of respiratory arrest. Okay. So remember, this is droplet precautions and contact precautions, right? Because people are coughing and the virus is landing on fomites, on furniture, on a desk, or all kinds of things. So it would be droplet and contact precautions. So we encourage fluids, right? We monitor intake and output to make sure that they're getting enough fluids. And what's the best way to know if someone's getting enough fluids? Well, you can either see them drinking the fluids or you can monitor urine output, because urine output is a very good indicator of overall hydration of the patient. Okay. And of course, monitoring respiratory status is important, right? So if they're breathing at 30 or 40 per minute, they're not oxygenating well, we're starting to get concerned that they may be developing influenza pneumonia. I mentioned the antivirals such as amantadine and another very common one that you may hear of called oseltamivir, which is Tamiflu. Countries stockpiled oseltamivir thinking that they might get a pandemic influenza. But now we know the medication really isn't that effective and it has significant side effects such as severe diarrhea. And it has to be taken typically in the first 24 to 48 hours. So not really that useful. Okay. The influenza vaccines can be very effective for mass vaccinations. Okay. And there's a new influenza vaccine that comes out every year that's based on prediction models of the influenza strains that are coming through. Okay. So you can have it from 6 months onwards. But typically patients that have high risk features such as a history of pneumonia, diabetics, patients over the age of 65, pregnant women, healthcare providers, they're highly encouraged to get the vaccine because they're at higher risk for getting influenza. Okay, so this slide's expected findings I've already spoken about. Remember, this is all from a viral illness, so no need for antibiotics with influenza. There's diagnostic tests, so nasopharyngeal tests where we put that swab right to the back of the nose, take a sample, and then send it off for viral studies for influenza. Okay. There's also rapid influenza tests that can be obtained to get a result even more quickly. Influenza comes in two versions, influenza A and influenza B. Influenza A tends to be a more severe illness compared to influenza B. Okay, so how do we minimize the spread of influenza? Well, we try to remind people to get their annual influenza immunizations. Proper hand washing and avoiding coughing on people is pretty critical. In fact, in hospitals, there's people that walk around seeing how staff are washing their hands to see if it's being done properly, because it's actually a bit of a skill to really wash your hands properly. Okay, so proper hand washing and cough etiquette. Avoiding places where there's lots of people gathering, especially in the winter, right? That's a very good way to get influenza, where you're gathering with large populations. Okay. If you do have influenza, so encouraging fluid intake, lots of rest periods, and staying at home so you don't spread it to other people. Okay. I mentioned the main complication of influenza, which is influenza pneumonia. Who's at risk for getting that? Well, patients that are immunocompromised, so they're on, say, chemotherapy drugs, or they have a disease where they're immunocompromised, they're more at risk for getting influenza pneumonia and then potentially dying from that. Older patients, of course, are at high risk because we consider them immunocompromised, right? Their immune system is starting to weaken over time, and their pulmonary function is not as strong as it used to be. So if they were to get influenza, their lungs are weaker to begin with, so it might hit them harder, and they're immunocompromised on top of that. Okay, so in the interest of time, I'm not going to spend much time on this slide. We spoke about the droplet and contact precautions. We spoke about maintaining proper hydration, um, monitoring input and output, administering fluids. Respiratory status is important. So someone who comes back um, having been diagnosed with influenza and now they're short of breath, they're weak, um, their O2 sat is in the 80s, say it's 85%. Then we're going to do a chest x-ray to see if they have influenza pneumonia, and they'll likely need to be admitted to hospital. Okay, and some patients end up on ventilators. I mentioned the antiviral medications. It can shorten the duration of illness by 6 to 12 hours. Usually we don't use them anymore because that's a pretty short length of time to shorten the illness with significant side effects such as nausea, vomiting, and diarrhea. Okay. The flu vaccines are critical to try and prevent this, even though they're only, say, anywhere from 20 to 40% effective. When you're vaccinating large populations, that's still a very useful vaccine. Okay, so here are all the symptoms of influenza. So the nasopharynx, the runny nose, the stuffy nose, the sore throat, the aches. I would think of this basically as a really, really bad viral illness, and the symptoms are much more severe. Okay, so compared to your typical run-of-the-mill viral bronchitis or acute bronchitis, this is much more, right? So it's a much more aggressive virus, influenza. We mentioned all these bullet points on the left, so I won't go over them again. Okay, so pneumonia. So pneumonia is common, right? And it can make people really sick. So you can have different degrees of pneumonia. You might have a mild small pneumonia in one lobe of your lung, or you may have bilateral pneumonia in multiple areas of both lungs. Okay, so pneumonia is infection, typically viral or bacterial, that is filling the alveoli with fluid and infection, causing a lot of inflammation. So what kind of problem is this? Well, it's going to end up being a diffusion problem, right? Because as the alveoli fill with fluid and pus, well, oxygen can't get there anymore. So the body's going to have problems oxygenating the blood, okay, because it's losing a segment of the lung to infection, right? And on top of that, when your lung is filled with bacteria and fluid and pus, it's gonna be not only be hard to perform diffusion, and that's why you're going to be hypoxemic, but it's going to also start to affect ventilation because it's hard to expand stiff area of the lung because it's filled with fluid. Okay, so it can affect diffusion, and as it gets larger and larger, it can actually affect ventilation because it's causing a stiff lung. So what are the symptoms? Well, sure, you could have some anxiety, you could have fatigue and weakness, which could go along with really with any illness. I mean, anxiety because you're short of breath, really. Chest discomfort because you're coughing so much. So let's think of the common symptoms: fever, shortness of breath, coughing, purulent phlegm production. So if they're coughing up phlegm, it's usually purulent in color. Okay, kind of greenish. Greenish phlegm. Okay, they can be confused. Why? Because they may be hypoxemic. Okay, and if you're hypoxemic, you don't get enough oxygen to your brain. You can get confused or agitated. Okay, so the The physical assessment findings, well, fevers and chills from the infection, sure. Flushed face from the fever, diaphoresis is sweating, shortness of breath, which is the same as dyspnea because there's a part of your lung that the body's having difficulty expanding, so the sensation of shortness of breath. Tachypnea, you're breathing faster to try and get rid of the CO2 and maintain oxygenation of the blood because there's a segment that's infected and filled with fluid. Okay? Tachypnea is breathing fast, sure. Okay. Pleuritic chest pain if the pneumonia is touching the pleura. So every time you take a deep breath, oh, it hurts because it's inflamed the pleura. The yellow-green sputum production. When we listen to the chest, focal coarse crackles. So if it's a left lower pneumonia, when we listen to the left lower area, there'll be coarse crackles and crepitations. It sounds like Rice Krispies when you put milk on them. Okay, and of course lots of coughing. Now you can have purulent blood tinged sputum, someone who's coughing up kind of this greenish yellow phlegm. It can be blood tinged with pneumonia. The area when you tap over it is dull to percussion because pneumonia is liquid and it's not air anymore, so it's not resonant, it's becoming dull to percussion. Okay, so diagnostics for pneumonia. So lab tests. If we're lucky, we can get a sputum culture. So if someone's really hacking up phlegm, not saliva, we don't send off saliva because it's not useful. But if they're able to give us a really good sputum sample, we'll send it for a culture and sensitivity that we'll get back 2 or 3 days later. And we'll typically try and do that before giving any antibiotics. Remember, we try and take samples for culturing before ever giving antibiotics, if possible. A chest x-ray, very useful for looking at pneumonia. Okay, chest x-rays can definitely pick up a pneumonia. As you can see in this image, there's a right upper lobe pneumonia, and you can see how it's opacified, it's all white. And it's because the x-rays aren't going through it, because there's fluid and pus and infection there. Other blood work. Sorry, I went off topic in terms of the chest x-ray. Let me come back. A CBC often will see an elevated white blood cell count. If it's a bacterial pneumonia, typically the neutrophils have a higher percentage of the white blood cell count. If it's a viral pneumonia, typically we'll see an elevation of the lymphocytes as the predominant elevated part of the white blood cell count. Okay. Arterial blood gases can be useful because, remember, this person may not be oxygenating their blood very well. And we're going to pick up a low O2 sat on pulse oximetry. And on arterial blood gases, we might see a low PaO2. We may see, again, a low O2 sat on the arterial blood gas. And if they're getting really sick, they're going to start retaining their CO2 because they can't clear it, because some of their alveoli are filled with pus and fluid. And we're going to see, if they start to retain CO2, we're going to start to see a drop in their pH. They're going to become acidotic, respiratory acidosis. Okay. Often we'll take blood cultures, especially if someone's complaining of fevers and chills and rigors. We'll take blood cultures. All of this is before antibiotics. I mentioned chest x-ray and I mentioned pulse oximetry. Sometimes even with a large pneumonia, on top of the chest x-ray, we'll do a CAT scan to see the extent of the pneumonia in the chest. Not always, but with a very extensive pneumonia, we may do a chest x-ray. A CAT scan. Okay, so let's just talk about someone who's lying in bed with pneumonia. Okay, so they may need oxygen because they're hypoxemic. Okay, so if there's enough of their lung involved, they may need administration of oxygen. whether it's in nasal prongs or a facial mask. It just depends on, when we look at the O2 sat monitor, how it's improved by the administration of oxygen. Okay. We typically have patients sitting upright if they're able to, right? When you sit upright, your diaphragm goes down and you're able to take better breaths. So most patients with pneumonia are not lying flat in bed because they're too short of breath. Okay? We encourage patients to cough and get all that phlegm out. Older people have difficulty getting those secretions and phlegm, and you can hear it just rattling in their chest. And that is unfortunately not a good sign, because it means they're unable to clear the secretions. Okay? While in bed, they may run into problems with bed ulcers. You often start to get skin breakdown around where you're receiving oxygen, right? Dry mouth, dry nose from the oxygen. We can encourage them to use an incentive spirometer to prevent atelectasis. So if they have a pneumonia, you don't want more collapse of other parts of the lungs, called atelectasis. So an incentive spirometer to make sure that they're keeping all the alveoli as open as possible. Okay. Making sure that they're getting proper nutrition, and they're drinking well to avoid getting dehydrated. Okay, so whenever you have an infection, you're actually using more energy to try and fight the infection. So maintaining proper nutrition, making sure that you're drinking well, which is typically 2 to 3 liters a day, and rest periods for patients who have pneumonia so that their body can fight the infection. Okay. So what else? Suctioning is definitely important. Patient can sometimes get some of the secretions up to a certain level, and suctioning can help remove that. Now, eye cough. So those bullet points under eye cough there: incentive spirometer, coughing and deep breathing, oral care, getting out of bed 3 times a day, head of the bed elevation. Those really sound like objectives of avoiding pneumonia, especially post-operatively. Okay, so the incentive spirometer is to make sure you don't get atelectasis. The coughing and deep breathing, same idea. Oral care, making sure that you don't aspirate bacteria from the mouth into the lungs. Getting out of bed, well, when you get out of bed, you're moving, your diaphragm's going down because of gravity, taking nice breaths. And that's what head of the bed elevation does, right? Making sure that you're getting nice breaths into the lungs, which prevent pneumonia. Now, in terms of medications, we're going to talk about those a bit more. Antibiotics, for sure, because I mentioned you can't tell if it's bacterial or viral pneumonia. Yes, we take sputum cultures, we take blood cultures, but they don't always come back positive, so we always treat pneumonia with antibiotics. What else can we use? Well, if someone has a lot of mucus in their airways, we can use bronchodilators. So sometimes we'll give people albuterol, which is a short-acting beta agonist, to just try and bronchodilate to get the oxygen down to their lungs. Cholinergic antagonists, I mentioned, they're bronchodilators as well, such as ipratropium. Methylxanthines, again, bronchodilators, that's theophylline. Again, theophylline, I mentioned, has a lot of side effects, a lot of drug interactions, and on top of that, you have to monitor blood levels. Okay, so a bit of a painful drug to administer and to take. Okay, now anti-inflammatories. Some patients with pneumonia, there's so much inflammation that we're going to use an anti-inflammatory, such as an inhaler, fluticasone. Often we'll use an oral glucocorticoid, such as prednisone, okay, to treat all the inflammation that's occurring in the lungs. Okay, make sure you know your side effects of glucocorticoids for any condition that they're being used for, right? So glucocorticoids, they reduce immunity. So in actual fact, you're more at risk for infections if you're on long-term glucocorticoids. They're going to stimulate release of sugar or glucose from the liver. You're going to develop hyperglycemia. They retain fluid uh, from the kidneys, so peripheral edema, weight gain. You get much more of an appetite as well when you're on glucocorticoids. So that's going to be another factor of gaining weight. Okay, they can thin the patient's skin significantly. Okay, so bruising and torn skin could happen. Thrush in the mouth can develop, and actually aphthous ulcers that we call canker sores, they can also develop. But thrush in the mouth from immunosuppression with glucocorticoids can definitely happen. They can lead to peptic ulcer disease. Why? They're really hard on the stomach, and they thin the stomach lining, which can lead to peptic ulcer disease, causing black tarry stools. That's melena. Okay. We always advise patients to take oral glucocorticoids with food. Okay, so if someone's taking prednisone, it needs to be with food because it irritates the stomach. And we also tell patients taking glucocorticoids, if you're taking them for more than 2.5, 3 weeks, you need to taper them. And that takes some advice in terms of tapering them. If it's just a short burst of a glucocorticoid, say 5 or 7 days, there's no need to taper. Okay. Okay, so I find myself saying information on the slide before. Um, I don't do it on purpose, it's just that it comes to my mind and I thought, oh, I better mention this. Okay, so treatments for pneumonia, we've covered this slide. Let's go into a couple of antibiotics. So penicillins and cousins of penicillins called cephalosporins are very common antibiotics for pneumonia. Okay. Remember, if you have a severe penicillin allergy, we don't give cephalosporins. If you have a mild penicillin allergy, such as a rash, then we do use cephalosporins because they're a cousin of penicillins. And with mild allergies, mild penicillin allergies, we can still use them. Okay. With antibiotic that we're administering, whether it's penicillin or a macrolide such as azithromycin or erythromycin, we get the cultures before. If we're going to take cultures, we get them before the antibiotic. Okay. The bronchodilators I mentioned, a beta-2 agonist such as albuterol, or a cholinergic antagonist such as ipratropium, just to open the airways a bit. And when we're talking about anti-inflammatories for pneumonia, it's going to be glucocorticoids. If they have a mild pneumonia, we could use fluticasone, which is an inhaled version. If they have a more severe pneumonia, we could use oral prednisone or methylprednisolone, which is IV. It doesn't really make much sense to give a drug that has immunosuppressive effects to someone who has an infection, but they tend to clear up the inflammation really well. So that's why we use them for short-term treatment of pneumonia. They don't stay on this for months and months, right? So it's for short-term treatment of the inflammation. Okay, so for patient education for pneumonia, remember, many patients with pneumonia end up going home. They don't necessarily get admitted to hospital, right? But someone who has pneumonia has low O2 saturations, or they're weak, sick, short of breath, then we'll admit them. Or if they're dehydrated. Or when we look at them, we notice you look quite short of breath, you're working hard to breathe, you're requiring a bit of oxygen in the emergency room. Okay, you need to stay with us for treatment. Okay, so, but there's a good percentage of people that go home with antibiotics, sometimes a bronchodilator such as albuterol, and a short course of, say, prednisone. Okay. What else is important? So I mentioned the medications, the maintaining a good hydration with fluids and good nutrition. to fight the infection. Spoke about ICOF, that acronym. Rest periods is important because you only have so much energy for a given day. So, if you have pneumonia, you want some of your energy to be diverted to fighting the infection. Okay. Proper hand hygiene to avoid spreading it, whether it's the patient or the staff that's caring for the patient. And recovery takes time, and it also depends on the patient. So someone who's very old and frail, it's going to take much longer to get back to their baseline compared to a 30-year-old with pneumonia. There's pneumonia vaccines, so pneumovax, to try and prevent at-risk patients from developing pneumonia or recurrent pneumonia. And of course, advising smoking cessation, right? So smoking is a risk factor for developing recurrent pneumonia, right? It's irritating the bronchial tubes, it's damaging the alveoli, and it puts people at risk for developing pneumonia. They can't clear their phlegm as well. The little cilia in all the bronchial tubes don't move as well, so they're more at risk for developing a pneumonia. So what are complications of pneumonia? Well, if the pneumonia is significant and it's a large portion of the lung or a lobe of the lung, well, the patient will become hypoxemic. They may have difficulty taking breaths. Their work of breathing might be significant and they may tire out and they would need to be intubated and ventilated. Okay. So we monitor patients with pneumonia for increasing respiratory distress, decreasing oxygen saturation levels, and that's usually an indication that they're starting to tire from the pneumonia, and they may end up on a ventilator. Okay. So another complication, atelectasis. So atelectasis just means other parts of the lung are collapsing because you're not taking good breaths from the pneumonia to begin with. Okay, and that's going to lead to more hypoxemia. Okay, and that's one of the reasons why we can encourage using an incentive spirometer to maintain or to avoid alveolar collapse in other parts of the lung. Bacteremia means that the bacteria from the pneumonia is now leaking into the bloodstream, and bacteremia leads to sepsis, right? Which is an inflammatory condition in the system, in your bloodstream, and of course all your organs, causing tachycardia, hypotension, confusion. Just depends on which organ you want to talk about. If it's the brain, confusion, agitation. If it's the kidneys, renal failure due to hypotension and all the inflammatory molecules that are blocking up the kidney. So sepsis is definitely a complication of pneumonia, and it's a bad complication. Acute respiratory distress syndrome can be from any severe illness, including pneumonia. So what happens is the pneumonia causes diffuse vasodilation of the blood vessels in the lung, and you get, when you have fluid all throughout your lungs, you get stiff lungs. They don't expand well, so they have reduced capacity, right? And you get more and more short of breath because now there's fluid throughout both lungs. Okay, and often these patients will end up needing a ventilator because they have reduced O2 saturations and elevated CO2 levels in the blood. Okay, so let's do the questions at the back of chapter 20. Okay, so a nurse is monitoring a group of clients for increased risk for developing pneumonia. Which of the following clients should the nurse expect to be at risk? Okay, so let's just talk about briefly the risk factors for developing pneumonia. So very, very young people, so infants and neonates, and old people are at risk for developing pneumonia. Both extremes have they have poorly developed immune systems if they're young, and they have declining immune systems if they're old. Patients that have been exposed to a viral or bacterial infection, they're at higher risk for developing pneumonia. Lack of immunizations, so they didn't receive their pneumovax or their influenza vaccine. Smoking. Smoking leads to COPD. COPD is a risk factor for developing recurrent pneumonias. Okay, so on top of having the COPD, you're developing recurrent pneumonias. Okay, not good. Alcoholism is a risk factor. So alcohol actually suppresses the immune system, and alcoholics are at risk for aspirating because they're sometimes semi-conscious or unconscious. Chronic lung disease, I mentioned. So COPD would be the main chronic lung disease that would lead to recurrent pneumonia. Anyone who's immunocompromised for any reason, whether it's from a disease they have or treatment they're receiving, such as glucocorticoids or immunosuppressants. The presence of a foreign body in your lung, say you aspirated something or you choked on something and it went into your bronchial tube. Well, that's a perfect place to develop a pneumonia, so a foreign body. So typically we have to go and retrieve foreign bodies. Okay? Any condition that puts you at risk for aspiration, difficulty swallowing after a stroke, decreased level of consciousness after a stroke or a head injury would be a risk factor for aspirating. Okay? Poor mobility. So you're immobile from a bilateral femur fracture and you're lying in bed. I mentioned decreased level of consciousness would be a risk factor for aspirating. On a mechanical ventilator, definitely a risk factor for developing a pneumonia. Okay, so let's look at the answers. A client who has dysphagia, so that's difficulty and discomfort with swallowing, yes, that would be a risk factor for aspirating. A client who has AIDS, well, they're immunosuppressed if you have AIDS, right? AIDS means that not only are you HIV positive, but you're at a point in the disease of having a human immunodeficiency virus that you have AIDS. And that's at a CD4 count, usually at 200, and you're at serious risk of developing pneumonia. A client who was vaccinated with pneumococcus and influenza 6 months ago, that wouldn't be a risk factor, that would be a good thing. A client who is post-operative and has received local anesthesia, no, that's not a risk factor if they received local anesthesia. If they had general anesthesia and they were unconscious, that would be a risk factor because they would have potentially required being intubated. But a local anesthetic is not a risk factor for developing pneumonia. A client who has a closed head injury and is receiving mechanical ventilation, definitely, right? So they have a foreign object down, they have an endotracheal tube in their lungs, and there's a machine breathing for them. Definitely a risk factor for pneumonia. Client who has myasthenia gravis, absolutely. Myasthenia gravis is a condition of the synaptic cleft. So you have reduced acetylcholine at the neuromuscular junction. So you're going to have ventilation issues. You're not taking good breaths, right? Because the neuromuscular junction at the intercostal muscles and the diaphragm aren't expanding your lungs properly. So you'll develop atelectasis and pneumonia. So the answer A, B, E, and F. Number 2, a nurse is caring for a client who, upon awakening, was disoriented to person, place, and time. The client reports chills and chest pain that is worse upon inspiration. Which of the following actions is the nursing priority? Okay, so they're confused, and on top of that, they have chills and chest pain. So chills makes me think of infection. Chest pain makes me think of an infection in the lungs, and the confusion makes me think of they're low on oxygen. Okay, So what's the first answer? A, obtain baseline vital signs and oxygen saturation. Absolutely. Number one. They could be hypotensive, and that could be making them confused. Their oxygen could be low, and that could be making them confused. So you need vital signs in O2 sat. Obtain a sputum sample. That's not a priority at all. Obtain a complete history from the client. That's not going to happen because they're disoriented. And that's not a priority. Vital signs are a priority. Provide a pneumococcal vaccine. Not a priority. It'll take weeks to work, and need the vital signs in O2 sat first in this person. Okay, they don't sound well. Okay, so the answer is A. Number 3, nurses caring for a client who has pneumonia. Assessment findings include temperature of 37.8, so low-grade fever, respirations of 30, that's on the high side. Typically we like to see respirations 12 to 16, 12 to 18. So 30 is high, they're breathing fast. Blood pressure 130 on 76, that's fine. Heart rate is high normal, 100. O2 sat is on the low side, 91%. They should be 95% or greater normally. Prioritize the following nursing interventions. Okay, so let's look at the interventions. Administer antibiotics, administer oxygen, perform a sputum culture, instruct the client to obtain a yearly influenza vaccine. Okay, so what's the first thing that needs to be done? Well, there are O2 sats on the low side. So we always have to think of ABCs, airway, breathing, and circulation. So it'd be nice to see that oxygen come up a bit and by providing oxygen therapy, because it'll come up quickly, typically with oxygen therapy. So B would be the first intervention. A would definitely be the second, right? So administering antibiotics early has been shown to have a better outcome for the patient as opposed to delayed antibiotics in pneumonia. Okay, so oxygen first. Sure, we'd want to get the antibiotics in second as for these choices. And then we can get a sputum culture after. No, sorry, I didn't see that one. It should be B, administer oxygen therapy, get the sputum culture. Sorry, I didn't see that answer there. And then give the antibiotics. It doesn't take long to get a sputum culture, and we always get them before the antibiotics. And then the annual influenza vaccine can be discussed at a later point. Okay. Number 4, a nurse in a clinic is assessing a client who has sinusitis. Which of the following techniques should the nurse use to identify manifestations of this disorder? Percussion of the lower lobes of the lungs. Well, sinusitis is of the face, right? So that's not going to be the answer. Those sinuses are in the face, right? The frontal sinus, the maxillary sinus, and the ethmoid sinuses are deep behind the nose. Auscultation of the trachea. No, that's not where the sinuses are. That's not going to help. Inspection of the conjunctiva. No. The conjunctiva is the lining of the white part of your eye, or above the white part of your eye. So that could be involved in conjunctivitis, but that's not part of sinuses. Palpation of the orbital area. So if we palpate the orbital area, so above the eye, or even below the eye, we could be looking for a frontal sinusitis or a maxillary sinusitis. Okay, so the answer would be D here. 5, a nurse is teaching a group of clients about influenza. Which of the following client statements indicates an understanding of the teaching? I should wash my hands after blowing my nose to prevent spreading the disease. Absolutely. Yep, proper hand washing. I need to avoid drinking fluids if I develop symptoms. Not true. You should be drinking a good amount of fluids with influenza to avoid getting dehydrated. I need a flu shot every 2 years. No, it's annual. I should cover my mouth with my hand when I sneeze. Not really. It's probably better to use your elbow as opposed to your hands, because then you have to just recurrently wash your hands. So coughing into your elbow, avoiding to cough into your hands. Okay, good. Okay, so let's move on to asthma, which tends to be a chronic disorder, but it's intermittent. Okay, so and it's reversible, meaning patients are going to have intermittent symptoms, and it's going to return back to being asymptomatic. Okay, so it's reversible bronchoconstriction. Okay, and inflammation of the airways. So there's two components to asthma: the bronchoconstriction and the inflammation of the bronchial tubes. Okay, and so if you remember that, you're going to remember all the treatments because they're going to address one of those two things: bronchoconstriction, airway inflammation. Okay, so a patient with asthma can be going along just fine with no symptoms at all and then have an asthma flare up. And then once it's treated and they get through it, they go back to breathing normally again. Okay, so it's intermittent and reversible. Okay. So asthma is can be referred to as basically twitchy airways. So patients are responding to something in the environment. So we would call that extrinsic asthma. So they're inhaling something that's just irritating their airways. And what are the airways doing? They're bronchoconstricting and becoming inflamed. Excuse me. Um, Intrinsic asthma just means there's nothing that someone's breathing in that's doing it. They're just getting flare-ups of asthma. Okay, so I wouldn't hold those terms too tightly, but I'm just telling you that some people are sensitive to extrinsic conditions in the environment, and some people just have intrinsic asthma where they just get recurrent episodes of bronchoconstriction and airway inflammation. So this image is just showing you the airway inflammation, okay, and bronchoconstriction. So on the left is a normal airway. The middle one is showing you some bronchoconstriction, okay? And you're not going to breathe very well through a very narrow tube. It's going to make ventilation more difficult. So it's going to feel like breathing through a straw, okay? And then on top of that, airway inflammation, okay? So, and when you have airway inflammation, you get more mucus production into the airways, and that's going to cause even more narrowing of the airway temporarily. Okay, so what kind of symptoms? Dyspnea, for sure, shortness of breath, right? The airways are irritated, coughing, wheezing, especially expiratory wheezing. If someone has inspiratory wheezing, that's a bad sign. That usually means that the airway is super narrowed. Okay, so expiratory wheezing is very common. Inspiratory wheezing, much more of a late finding, more serious. Mucus production in asthma, yeah, we just mentioned that there's a lot of inflammation. As the asthma gets worse, could you be using your accessory muscles in your neck? Yes, right? Because the body's saying, okay, I have to open up this chest and I have to push out the air during exhalation. So I'm going to use more muscles. Prolonged exhalation, yeah, because of all the mucus and bronchoconstriction, you can't get all the air out. So we usually think of asthma as a condition of difficulty exhaling the air. Okay, it can get to the point of difficulty inhaling the air, but typically patients have come looking for help during the expiratory wheezing phase. Okay, poor oxygenation, yeah, because they're having difficulty ventilating. They're having difficulty getting the air to the alveoli. So as it gets worse and worse and worse, they're going to have hypoxemia, right, and low O2 sats. Increased chest diameter, they can have that during a flare-up. Why? Well, they breathe in air, they can't get it out. They breathe in air, they can't get it out. So they're breathing at higher lung volumes because, as I mentioned, asthma is a difficulty with getting the air out usually. Okay. So what about an exacerbation of asthma? So patients going along fine. They're taking their fluticasone inhaler regularly to prevent asthma exacerbations, and then they get, say, a cold, and then the cold settles in their chest, and they get an asthma flare-up. So they begin with shortness of breath and wheezing. What are precipitating factors? Well, it could be something in the environment. It could be a viral infection that started with a cough and then that triggered their asthma. So remember, asthma is like twitchy airways. So anything that irritates the airways um, may put them into an asthma exacerbation. Okay. Uh, what else would you ask about in terms of an exacerbation? So you want to know about the onset. Anything that precipitated it. Are you visiting someone's cottage? Are you living in a basement? Are you smoking? Anything like that. What medications the patient's on? What inhalers? Are you on a short-acting beta agonist? Do you take a inhaled corticosteroid? Things like that. Methods to relieve the asthma. Do you use your short-acting beta agonist? How frequently do you use it? We often don't like to hear that someone's using their albuterol frequently. That means their asthma is not under good control, and we may need to adjust one of their long-term control medications, such as fluticasone, okay, or maybe a long-acting beta agonist, such as salmeterol. Okay, so asthma diagnostic. So how do we diagnose someone with asthma or an asthma flare-up? So really it's by history first, right? So someone comes in and says, every once in a while I'm short of breath and wheezing, and then it settles, and then it comes back when I get a cold that I start to get short of breath and wheezing again. So it's intermittent and recurrent, right? So if someone comes in shortness of breath with wheezing, what kind of tests might we use to diagnose asthma and to see the severity of the asthma? So we can use labs if someone comes in short of breath and wheezing to see the severity of the asthma. It's not going to diagnose the asthma. So they might be hypoxemic on an arterial blood gas. Initially, because an asthmatic is breathing fast, right? Breathing fast to try and maintain that oxygen going into the lungs, but they're blowing off the CO2 faster. So initially, we'll often see patients with a low CO2 because of the fast respirations. They're able to blow off the CO2. Okay, so as the asthma gets worse and the bronchial tubes get tighter and tighter and more inflamed, well, now they're going to start getting tired, right? It's getting harder and harder to breathe, and they're not able to breathe at those fast rates for very long. So they're going to start to get an elevation in CO2. That's a bad sign. So if we see an asthmatic that has increased CO2 in the blood, we start to think that this person is tiring out and they may need to be intubated. We much prefer to see a low CO2 just because they're breathing fast. Okay. Sputum cultures are going to be negative in asthma if it's just asthma because there's no infection as part of asthma. Procedures. So pulmonary function tests are usually done when the patient has recovered from their asthma flare-up. So we send them to a lab to have pulmonary function tests, and that can really help us diagnose asthma. So they're going to have difficulty getting the air out, and that's going to be picked up on a pulmonary function test. Okay. So pulmonary function test is one of the primary ways that we're going to diagnose asthma. So when we tell them to breathe out their vital capacity, they have difficulty getting out all of the oxygen. All of the air. Okay, because they have airway narrowing. Okay. A chest x-ray is going to be typically normal in asthma. We will sometimes get a chest x-ray just to make sure that it's nothing else that has brought them in with shortness of breath and hypoxemia. But if it's just asthma, we don't see much on the chest x-ray because it's not a lung problem. It's a bronchial constriction and airway inflammation problem. So we don't see it on chest x-ray. Okay, so let's just talk about a couple of interventions. So if someone comes in with mild to moderate asthma, okay, we're going to put them on a bed and we're going to um, check their vital signs, check their oxygen saturation, and then we can just provide them with, say, a nebulized treatment of albuterol. Okay. And typically those patients get better once we bronchodilate their lungs. And then we talk to them about taking regular albuterol at home. We might start a fluticasone inhaler. If they're not on a fluticasone inhaler, we can start it. If they are on one, we'll often introduce oral prednisone to settle down the inflammation. Okay. So what about someone who comes in sicker with asthma? So they have more bronchoconstriction and more airway inflammation. Well, we keep them upright in bed because that's going to help them breathe better. These patients would never want to be laid down in bed. Okay, they're much too short of breath. Often they're anxious and nervous about the condition, that they can't get air into their lungs, so they're anxious. We put them on a cardiac monitor. We put them on continuous oxygen saturation monitor. And we're going to get frequent vital signs. Okay. We definitely try to calm down the patient and talk to them slowly and explain what we're going to do because they're often anxious about not getting oxygen into their lungs. Any of us would be, right? So administration of the medications, we'll talk about the medications. We've already spoken about them. Which ones do we use? Well, beta-2 agonists, albuterol, right? If they're really short of breath, we can put beta-2 agonists such as albuterol into a nebulizer. We can add some ipratropium, that anticholinergic drug, which also comes as an inhaler, but it comes as a liquid that we can use in a nebulizer to bronchodilate. Okay. We can use theophylline. I'm going to tell you I haven't used theophylline in over 25 years. Well, 20 years. Because it just has so many side effects and it's not overly effective. Okay. That doesn't mean that you don't need to know a bit about it, but it just means it's just not used very often anymore. Okay. We're typically going to start glucocorticoids, right? So if someone's really sick, we're going to give it to them IV, such as methylprednisolone. If they're moderately sick and they can take oral medications, we may start oral prednisone. So with albuterol, which is a beta-2 agonist, what are the adverse effects to watch for? Well, they're going to get tremulous. They often get tachycardic, and they get nauseated with it too. Okay. Ipratropium, the anticholinergic, dry mouth. In terms of theophylline, tachycardia, jitteriness. Just think of taking 6 cups of coffee. It's going to have a similar effect. Nausea, tachycardia, just agitation is going to happen with theophylline. Okay. Remember, salmeterol is a long-acting beta agonist. We don't use that to break an asthma attack. That's to prevent asthma attack. That's a long-term treatment. Okay. So what else can we use? So, okay, could we use leukotriene antagonists to treat asthma? Sure, such as montelukast. We don't because they're not very effective. Mast cell stabilizers like cromolyn, Sure, because there is an allergic component to asthma. We don't because they're not very effective. Monoclonal antibodies, that would be for long-term control of someone with severe asthma that we've tried everything else. Okay, so in terms of anti-inflammatories, we really go to the corticosteroids. Fluticasone in an inhaler form, prednisone in an oral form, methylprednisolone in an IV form. So let's just look at some common asthma medications again. And you can break it up into medications that patients are taking long term to control their asthma. So we'll call those long-lasting medications, and medications that patients are taking in the short term to either because they have an asthma flare-up or they are, say, visiting someone's cottage and that's what caused their asthma flare-up. Okay, so short-acting medications to break an asthma flare-up, and then long-term control medications. Okay, let's start with long-term control. So what kind of medication might someone be on a daily basis to prevent frequent asthma exacerbations? Well, definitely the inhaled corticosteroids, right? So fluticasone, which is Flovent, and there's a whole bunch of other ones. These are brand names, Pulmicort and Qvar, but they're all the same. They're all inhaled corticosteroids. There's really not one better than another. Okay, they're all effective if they're taken regularly. Remember, they're not used to treat an acute flare-up. Okay, they're for long-term control. Some people might need to be on systemic corticosteroids longer term. That's the rarity. Most people don't need to take prednisone long term, luckily, because of all the adverse effects that would cause, right? Just think of being on prednisone long term. Peptic ulcers, thin skin, diabetes, cataracts, hypertension, fluid retention with peripheral edema, thin skin with bruising, moon face, all those Cushing symptoms, weight gain, increased appetite, insomnia. That's all from glucocorticoids. Okay? Luckily, most patients don't need to remain on prednisone. Long-acting beta-2 agonists that you would take twice a day to keep the tubes open, yes, such as salmeterol, okay? Or combined medications. So Advair is just a combination medication of a long-acting beta agonist and a inhaled glucocorticoid. Remember, there's two parts of treating asthma, right? There's the bronchoconstriction and the airway inflammation. So it's always going to be, treatment's always going to be aimed at one of those. Okay, so when I mentioned Advair, well, that's fluticasone and salmeterol. Okay, so you're just addressing the two parts of the condition long term. Leukotriene modifiers. We thought these would be great because they block some of the inflammation. So Singulair is one of them. Not very effective. We often don't use them. Okay. Mast cell stabilizers, I think they're basically disappearing from the market, but cromolyn would be a mast cell stabilizer. Again, we thought it would reduce allergies and inflammation, and that's why they were used. Okay. And lastly, monoclonal antibodies. Again, that's for really severe asthma. That would not be for your average person with asthma. Okay. Short-acting medications. So if someone comes in and they have a flare-up of their asthma, so they were going along just fine, they were taking their fluticasone inhaler, and they got a cold. And the cold triggered their really twitchy airways to bronchoconstrict and increase inflammation. What can we use? Well, short-acting beta agonists, those are the rescue medications, right? Albuterol. Those are the side effects, the increased heart rate, the shaking, the nausea, tremors. But but this is what we give in the emergency room. So albuterol, and often we'll combine Atrovent, which is ipratropium, in the same nebulizer. We'll just give it to them as a nebulizer to bronchodilate. Okay, so that's one arm of the treatment, the bronchodilation. What's the other arm? To decrease inflammation. What do we use for that? Corticosteroids. So if it's really, really mild asthma, okay, we'll give them inhaled corticosteroids such as fluticasone. If it's anything else, moderate, severe asthma, they're either going to get oral prednisone or IV methylprednisolone. Just depends on whether they're going home or they're staying in hospital. Okay, and of course, remember all the side effects of the cortisones. Really important. Okay, so what about complications of asthma? Okay, let's just talk about the first one. So someone who's asthmatic and they come in really short of breath, they're sweaty, they're pale, they're fearful, their eyes are dilated, they know they're in trouble, right? Well, they could run into respiratory failure. Their airways are so narrowed that they just can't get the air to the alveoli. They're having difficulty breathing in air and in particular exhaling air, and they go into respiratory failure. Well, those patients usually need intubating and mechanical ventilation. Okay, that's really severe asthma, and intubating in asthma is not taken lightly, because you can imagine trying to push air through a mechanical ventilator with really narrowed airways. Even the ventilator has trouble pushing the air through the narrowed airways. Okay. Status asthmaticus is another one, and this is someone that we just can't break the bronchoconstriction and all the inflammation in the lungs, in the bronchial tubes, with the medications such as albuterol, ipratropium, and oral or IV corticosteroids. So they just continue to wheeze, increased work of breath, using their accessory muscles, and we can't break the cycle. And they usually need intubation as well, right? And on top of that, they're going to need oxygen therapy. They're going to get bronchodilators through the endotracheal tube, or through the ventilator. We can mist in bronchodilators. We can use epinephrine, which is a very strong beta and alpha agonist. So that's going to help bronchodilate. Okay. And of course, we start IV steroids. Okay. I wasn't looking at the slide here while I was talking, but let me look at it. So expected findings. Well, expected findings of status asthmaticus is someone who's gasping for air. They're breathing fast, they look desperate, they're anxious, sweaty, and pale. Okay? In fact, when their wheezing disappears, when we hear a silent chest in a patient with status asthmaticus, that's a really bad sign. If we don't hear any wheezing on exhalation or inspiration, and we hear basically a silent chest, that means they're going to go into respiratory failure. Okay. Status asthmaticus, initially they might be in respiratory alkalosis just because they're breathing fast. Okay, they're breathing fast, they're blowing the CO2 out. Okay, so when you blow your CO2 out, your pH is going to go up because you're breathing so fast to try and maintain oxygenation, you're actually breathing out your CO2. But then they start to fail. They start to fatigue and fail, and they retain their CO2, and then it becomes respiratory acidosis. Okay. So what do? Continuous albuterol nebulizers, one after the next, after the next. Okay, we'll try that to try and break it, the status asthmaticus. We'll add ipratropium to the albuterol. We will give them IV magnesium. So magnesium is a smooth muscle relaxant. So it relaxes the smooth muscle, trying to bronchodilate those tubes. We'll give them IV epinephrine to bronchodilate the tubes. So we're basically throwing everything at them. We'll give them IV methylprednisolone to try and reduce the inflammation, but all the while preparing for intubation if all of these things are failing. Okay, so we're basically throwing the kitchen sink of medications at someone with status asthmaticus. Okay, so oxygen, bronchodilators such as albuterol and ipratropium, IV epinephrine, IV steroids, and then unfortunately some patients still need to be intubated. Okay, so definitely anyone who's asthmatic, it's a bad idea to smoke. It's a bad idea to smoke in general, but definitely if you're asthmatic, because you're inhaling toxins, which are going to trigger the asthma, right? So advice on quitting smoking is really important. Avoiding triggers. So some patients know what will trigger their asthma, whether it's a viral infection, which is hard to avoid, or it's going into someone's basement, or visiting a cottage that's moldy and dusty, or it's seasonal allergies, or chemicals at work. They usually know that there's certain things that trigger their asthma. Okay. Administering inhalers. So we often advise use of an aerochamber or a spacer, another term for it, while using metered dose inhalers, right? Now, some medications also come in a dry powder form, so you don't need the aerochamber. Okay, so aerochamber just makes it easier to get the medication lower into the lungs where it needs to be. Okay, so often they just need advice on how to take the inhaler, right? Shaking it well first, putting it to the aerochamber, administering the proper metered dose inhalers, and then taking 2-3 deep breaths to hold the medication in the lung. Okay? The importance of keeping to the medication. So the long-term medication needs to be taken regularly every day. You need to take your long-acting beta agonist if you're on one. Definitely your daily inhaled corticosteroid is critical to preventing asthma flare-ups. Okay? And remember that asthma often lives with other conditions. So patients often will describe, I have allergic rhinitis, so I've got an itchy nose, I'm sneezing a lot. So they're kind of sensitive to a lot of things. It's not just asthma by itself. I have eczema, which is atopic dermatitis. So I have itchy, dry skin that cracks open sometimes. Oh, and on top of that, I have wheezing and shortness of breath. So all of these kind of live together. Okay. And often we'll hear of, when we're asking about family history, that there might be a sister or brother that has asthma, or there might be a sister or brother that has eczema or allergic rhinitis. So asthma runs through families, but the other conditions that are associated with asthma, eczema and allergic rhinitis, or other allergic type symptoms, often run through the whole family as well. Okay, so someone might say, well, I have seasonal allergies, and my brother has asthma, and my sister has eczema. Okay, they all tend to run together. Okay, so let's do the questions at the end of the chapter. Number 1, a nurse in the emergency department is caring for a client who is experiencing an acute asthma attack. Which of the following assessments indicate that the respiratory status is declining? Well, I don't really like this question because declining from what? From normal? So let's just assume it's declining from normal. A O2 sat of 95%, well, that's normal, so that's okay. 95 to 100% is normal. Wheezing isn't normal, so we'll include that because you shouldn't usually wheeze, and that can be an indication of asthma. Retraction of sternal muscles. So if you're using accessory muscles, say in your neck, that's an indication that you're working harder to breathe, and that can happen in asthma. Pink mucous membranes is normal, right? Your mucous membranes are usually pink, so that's not concerning. If they were bluish or cyanotic, that would be concerning. Tachycardia. Well, as the asthma gets worse, or you're taking lots of albuterol, you're going to be tachycardic. So if you're getting more short of breath, your body is sensing that you're having to breathe faster to get oxygen into your blood. And on top of that, the body's increasing heart rate to deliver more blood to the lungs and to the body. So tachycardia would be an answer. So B, C, and E. Number 2 is a nurse is caring for a client 2 hours after admission. The client has an O2 sat of 91%, that's on the low side, exhibits audible wheezes, and is using accessory muscles when breathing. Which of the following classes of medication should the nurse expect to administer? So this is someone who has a low O2 sat, wheezing, and is using accessory muscle use, so they're working a bit hard to breathe. So an antibiotic, no, that's not going to rescue them. A beta blocker, I hope not. That's for blood pressure. An antiviral, no, there's no indication of needing a treatment with an antiviral. Beta 2 agonist, bronchodilate those bronchial tubes. Get the person breathing better, right? Their O2 sat will go up. They won't need to use their accessory muscles, and the wheezing will resolve. Okay. Number 3, a nurse is providing discharge teaching to a client who has a new prescription for prednisone for asthma. Which of the following statements indicates understanding? I will decrease my fluid intake while taking this medication. I don't think you need to decrease your fluid intake. I mean, one of the effects of prednisone is you're going to retain fluid and have a bit of peripheral edema, but I don't think you need to decrease your fluids while taking this medication. I will expect to have black tarry stools. Well, you shouldn't expect to have black tarry stools. You may get them if you develop a bleeding ulcer, because those are symptoms of or signs of melena. I will take my medication with meals. Absolutely. Glucocorticoids such as prednisone are hard on the stomach. They can cause gastritis and peptic ulcers. I will monitor for weight loss while on this medication. No, you will likely gain a bit of weight if you're on this medication for weeks or months. Okay, so it would be weight gain. So the answer is C. 4, a nurse is assessing a client who has a history of asthma. Which of the following factors should the nurse identify as a risk factor for asthma? Sex, environmental allergies, absolutely. Alcohol use, not usually. History of diabetes, not usually. So environmental allergies would be a risk factor because remember I mentioned asthma often lives with hay fever and allergic rhinitis, so the answer would be B. Okay, last question. A nurse is reinforcing teaching with a client on the purpose of taking a bronchodilator. Which of the following client statements indicates understanding? This medication can decrease my immune system. No, corticosteroids can, but bronchodilators such as albuterol and ipratropium don't. I take this medication to prevent asthma attacks. I mean, that's not really a fair question. Are you taking it to prevent? Well, you might be taking it to treat an acute attack if it's a short-acting beta agonist. If it's a long-acting beta agonist, then you would take it to prevent asthma attacks. So let's come back to the answer. I need to take this medication with food. No, you don't usually need to take a bronchodilator with food. They're usually inhaled or nebulized, so you wouldn't need to take it with food. This medication has a slow onset to treat my symptoms. No, beta agonists I don't like this question because it doesn't actually tell you which bronchodilator we're talking about here. So we need to make assumptions. Uh, the medication has a slow onset. No, beta agonists can have a rapid onset. So, I mean, I guess the best answer here is B. I take this medication to prevent asthma attacks since salmeterol is a long-acting beta agonist that's a bronchodilator, or ipratropium, and salbuterol is a short-acting one to treat acute attacks. I'm not a big fan of this question. Okay, I better speed up here just because of time. So chronic obstructive pulmonary disease. So this is a chronic condition that has two parts to it, right? So emphysema, which is alveolar uh, destruction, so lung destruction, and chronic bronchitis. So emphysema and chronic bronchitis. Okay, chronic bronchitis is excessive mucus production and chronically damaged bronchial tubes. By far the most common cause, smoking. Um, in a distant second would be air pollution. Okay, and it's irreversible. It's a chronic condition. Okay, there's actually a genetically inherited version of it called alpha-1 antitrypsin deficiency, where patients develop COPD. Okay, because in that condition you lose the elasticity and recoil of the lung. Okay, and what happens is because of the emphysema, you're going to lose surface area of the lung, and you're going to have difficulty exchanging gases, um, such as oxygen and CO2. Oxygen and CO2. And on top of that, you have the chronic bronchitis and excessive mucus production. So you're going to have wheezing, shortness of breath. Okay, and we'll talk about those. So really the key in terms of prevention is getting people to quit smoking and avoiding secondhand smoke. Okay, wearing proper equipment in potentially dangerous environments where there's particles that can get into the lungs and damage them. So workplace environment is really important. Um, Patients with COPD should definitely have an annual influenza vaccine and also have a pneumonia shot, a pneumovax, to prevent significant flare-ups of their COPD because they're at risk of getting recurrent infections, right? So what are the main risk factors for this disease? Well, the older we get, the more lung damage we can incur. And the biggest risk factor, smoking. Alpha-1 antitrypsin deficiency, I mentioned, is a genetic condition that can lead to COPD. Okay, so you don't need to be a smoker necessarily to have COPD. And exposure to rising levels of air pollution can damage the lungs because of all the particulate matter and lead to COPD as well. So here's the two components of COPD. Emphysema, okay, that's the alveolar destruction. And when you destroy the alveoli, you lose lung elasticity, meaning the lungs are becoming floppy. So you can inhale really easily, but there's going to be chronic bronchitis with this, so it's going to be difficult to exhale completely. And we'll talk about that. So hyperinflation of the lungs is due to the fact that the lungs can't recoil anymore. They've lost their recoil ability because the lung tissue is being destroyed. So they typically breathe at very high lung volumes because they don't completely exhale. And that's why they're going to have a barrel chest. Okay, the other component, chronic bronchitis, which is inflammation of the bronchial tubes, causing the wheezing, the chronic mucus production, the chronic coughing up of phlegm. So what are the expected findings of someone with COPD? Well, definitely dyspnea on exertion. And if it gets really bad, it'll be dyspnea at rest. So just sitting there, some people are short of breath all the time. Um, and it just depends on the severity of the COPD, right? And just keep in mind what's happening. The chronic bronchitis with the wheezing and chronic cough, and the alveolar destruction with the low O2 sats and the difficulty clearing CO2 out of their body. Productive cough is always there with COPD. They have a productive chronic cough with phlegm production. Okay, hypoxemia, so low O2 sats, because they're losing their diffusion ability at the alveolar level, because they're losing alveoli. Crackles and wheezes in their chest, well, the wheezing is from chronic bronchitis. The crackles and crepitations in their lungs that we hear are from the lung damage and scarring. Tachypnea, they're having to breathe faster to maintain oxygenation and trying to clear the CO2 out of their blood. Shallow respirations is really because they're breathing at higher volumes all the time. They're not completely exhaling, so they're always breathing at the higher volumes. So they take smaller breaths because they're always breathing at those higher volumes, right? Barrel chest is for the same reason, because they're not completely exhaling. They always have a larger appearing chest because they always have higher lung volumes in them. Thin extremities, why? Because they're chronically using more energy to breathe. So they're often thin. Okay, they don't have to be, but they're often thin because of that. Sometimes they have to use their their accessory muscles of respiration. So they may have enlarged neck muscles. Dependent edema, so edema in their legs. Why? Well, they can start to develop cor pulmonale or right-sided heart failure because the blood vessels are being destroyed in the lungs as well. And that's causing pulmonary hypertension in the pulmonary artery. And that's going to cause the right ventricle to fail, which causes peripheral edema. Clubbing of their fingers and toes can happen because this is a chronic hypoxemic condition, and that's what gives you clubbing. Okay? So whether it's a chronic cardiac condition or chronic lung condition such as COPD or cystic fibrosis, you can develop clubbing. Cyanosis, sure, that's deoxygenated blood. So if they have poor O2 sats, they can be cyanotic. So blue lips, blue fingernails, okay? And of course, decreased O2 saturations on a pulse oximeter can definitely happen. Many patients with COPD actually have, at a normal baseline, a low O2 sat of say 88%, 89%. Okay, they just live at that level. They're never in the normal range. Okay, so let's look at some diagnostics for COPD. I mean, not all of these tests directly lead you to a diagnosis of COPD. They just can help when they're all kind of put together, a diagnosis of COPD. So increased hematocrit. Well, if you're chronically low on oxygen in your bloodstream, that's going to trigger um, uh, uh, your bone marrow to make more hemoglobin, right? It's going to trigger production of erythropoietin from your kidneys. That will go to the bone marrow and say, make more hemoglobin. So because of the low oxygen, they can have an elevated hematocrit. In fact, smokers often have an elevated hematocrit because they have chronically low oxygen because it's being replaced by carbon monoxide. Someone with COPD, if they have a flare-up, sure, we could get sputum cultures. We could do a CBC, looking at their white blood cell count to see if it's elevated. Okay, so sputum cultures to see if they're bearing an infection. White blood cell count to help us to see if there's a infectious process occurring, because COPDers are at risk of getting recurrent pneumonias. Arterial blood gases can be used to determine the level of hypoxemia. So we're going to get a PaO2 and we'll get an O2 sat on an arterial blood gas. And also, what's their CO2 level? Are they still able to clear their CO2 from their bloodstream and have a CO2 level between 35 and 45? Or do they retain CO2 because their emphysema or COPD is so bad that they're not able to clear their CO2 out of their bloodstream? Okay. What tests can we get? Breathing tests. So pulmonary function tests can be obtained. How are they going to help? Well, usually these patients have difficulty getting air out, like in asthma, because they have all that mucus and bronchial damage. So they have difficulty forcing the air out fast. So their what's called forced expiratory volume is diminished. They can't get the air out fast. And in particular, what's called the forced expiratory volume in 1 second is low. So they can't get much air out very quickly. And as it gets worse and worse and worse, their forced expiratory volume that they can do in 1 second is vastly diminished because they just can't get the air out very fast. Okay? So if given a long time, they can get the air out, but how much they can get out in 1 second is vastly diminished. Okay, so pulmonary function tests are really used to help us see lung volumes and how much air someone can get out when they exhale. Okay, chest X-ray, yeah, that's going to help. It's going to show hyperinflated lungs because they're not getting the air out, so they're breathing at high lung volumes. Flattening of the diaphragm will occur as well. And if we really don't know the cause of someone's COPD, we can do a blood test looking for alpha-1 antitrypsin. Okay, and this would only be in someone who has COPD. They're not a smoker. They haven't been exposed to pollutants, and we think maybe this is inherited. Okay. Okay, so there's pulse oximeter, which is an O2 saturation monitor. And I mentioned that often patients with COPD live at relatively low O2 saturation, say of 90% or 88%, and that's just their baseline. Okay, and that will matter because when they come back with a COPD flare-up, we always like to know what's their baseline oxygen saturation. Because if it's about the same, well, that's good. They're able to maintain the same oxygenation in their blood. But if it's vastly diminished, we know that that compared to their baseline, they're performing poorly and they're not oxygenating their blood very well. Sorry about that. Okay, so what can we do with someone who comes in with a COPD flare-up? Well, positioning, so upright. Sometimes if they're having a significant flare-up, they're leaning forward and they're tripoding. They're holding the table in front of them to try and stabilize their chest wall. Sitting in high Fowler's position is a good idea. So upright in the bed to get as much oxygen flowing in and out of the lungs. These people would not lie down flat for sure. In terms of the airway, suctioning to see if you can help them with thick secretions. The ICOF acronym that we already spoke about. Assessment, well, they typically have increased respiratory rate because of all the mucus and bronchoconstriction, and they're hypoxemic, so the brain is making them breathe faster. They often have a prolonged expiratory phase, right? They're wheezing, so they can't get that air out very well. Okay. In terms of monitoring, so skin breakdown, especially if they're receiving a lot of high flow oxygen, so whether it's around their nostrils or drying out their mouth and causing ulcers or skin breakdown around their mouth, that's important. Administration of medications we'll talk about. A lot of them are very similar to asthma. Chest physiotherapy, where we can percuss different parts of the lungs to try and release some of the secretions and mucus that's making them short of breath. Remember that with oxygenation, we don't want to over-oxygenate them. So if someone usually lives at 88% on an O2 saturation, we don't want to get them to 99%, because at 88%, that's telling the brain, keep on breathing at this rate for this person. And if you get them up to 99% with oxygen, the brain's going to say, you don't need to breathe as fast. You don't need to breathe as deeply. And they're going to slow down their breathing, and they're going to retain carbon dioxide, which is going to make them lethargic, tired, and potentially need intubating. Okay, so we're careful with COPDers not to give them too much oxygen. Okay, we just want to get them to their baseline. We don't want to get them to a normal O2 sat of 95% or greater. Okay. Adequate nutrition is important because they use a lot of energy because of the increased work of breathing. Okay. Now, what else can we do with someone who comes in with COPD? Let's talk about some medications. So they're very similar to asthma. The short-acting beta agonists to bronchodilate, ipratropium, which is the anticholinergic, to also bronchodilate. Sometimes theophylline, which is a methylxanthine, to try and also bronchodilate, right? It's a bronchodilator, similar to caffeine. Okay. We can use corticosteroids, whether it's in an inhaled form or an oral form such as prednisone, or in an IV form. We can use those. We use them all the time to try and settle down the inflammation in the lungs. We definitely put patients on antibiotics for a COPD flare. So if someone comes in more short of breath, more mucus, more purulent phlegm, we can use all of these inhalers and bronchodilators and corticosteroids, plus we put them on an antibiotic because often they've developed a bacterial infection. Okay, so these COPD medications we've spoken about, so it really depends on whether we're talking about someone who's just being maintained and treated for their COPD versus someone who comes in with a COPD flare-up. Okay, so in terms of bronchodilators, albuterol and ipratropium can certainly be used regularly to keep their airways a bit open. Anti-inflammatory agents, usually we'll try and give them inhaled anti-inflammatories such as fluticasone, but during a flare-up, we will give them oral prednisone. Okay. The bottom ones, the montelukast, which is that leukotriene inhibitor, cromolyn, which is a mast cell stabilizer, they're not overly effective for this condition. Definitely the corticosteroids are the mainstay in terms of anti-inflammatory agents. Mucolytics, if we think they just can't cough up all this thick phlegm that's stuck down there, and we can give them acetylcysteine as a nebulizer. Don't forget, with a COPD flare-up, we give antibiotics because a lot of these patients have an underlying bacterial infection that's caused the flare-up to begin with. So in terms of patient education, COPD is typically a progressive disease. So a progressive decline in lung function from chronic bronchitis and emphysema. And there's a percentage of people that are going to develop right heart failure, right? Because of that pulmonary artery hypertension. And when they develop right heart failure, they're going to have peripheral edema. They're going to have an enlarged heart. They're going to have an enlarged liver because there's backup of blood because it can't leave the right ventricle very well to get to the lungs due to the hypertension in the lungs. When you have backup of blood, don't forget you'll have an enlarged liver, but what drains to the liver? Well, all the nutrients from the small intestine, right? So, and all the blood is going to be engorged in the veins around the small intestine. So often these patients say, I can't eat very well, I fill up really quickly, I'm nauseated when I eat, because the blood's not flowing very well from the small intestine to the liver, okay? And of course they have swollen feet with right heart failure. Some patients need to go home on home oxygen, so they're going to need education about not smoking. Well, actually, they should stop smoking because continuation of smoking results in a faster decline in COPD. But on top of that, home oxygen, you really can't smoke and be on oxygen therapy at the same time, just because it's combustible. Okay. High caloric intake, important because of all the energy they're using to maintain ventilation. Okay. Discussing rest periods throughout the day because they're working so hard to breathe, right? And remember, some people are short of breath even at rest. Adhering to the medications is really important. Their bronchodilators and their anti-inflammatories, and also being educated about when to come back if they have a COPD flare-up. They're more short of breath. They're coughing more. They're producing more phlegm. That's typically a COPD flare-up. Okay. Making sure that they take the annual flu vaccine and they get a pneumonia shot. That's important. Some people go to pulmonary rehabilitation clinics where they have exercises that they receive regularly for pulmonary rehab. Okay, and maintaining a good fluid intake, assuming you don't have heart failure. Okay, if you have heart failure, then we typically don't recommend large volumes of fluid. Okay, so let's do the questions at the end of the chapter of COPD. Just before then, I'm just going to mention two complications of COPD. So the first one is recurrent lung infections and COPD flare-ups, right? So patients come in with a history of COPD, but now they've come in more short of breath, more sputum production, and discolored sputum, okay? So typically they need higher levels of oxygen if they're on home oxygen, or they just need oxygen therapy if they're not on oxygen at home. We monitor their oxygen levels. We often will do blood work looking for an elevated white blood cell count, and they also need antibiotics on top of bronchodilators and glucocorticoids. Okay, so we want to open up the airway. We want to treat the infection with antibiotics, and we want to decrease the inflammation with glucocorticoids such as prednisone. Other complication is right-sided heart failure. So with COPD and alveolar destruction from emphysema, you also get destruction of tiny capillaries. And that leads to difficulty for the blood to flow through the lungs because the capillaries are being destroyed. And that causes pulmonary hypertension. So pulmonary artery hypertension. And the poor right ventricle now has to pump against higher pressures to get blood into the pulmonary artery. And that's going to lead to right ventricular failure because it's working harder all the time. Okay? And it's called cor pulmonale. So they're going to get symptoms and signs of right-sided heart failure. So what are the symptoms and signs? We mentioned them already. So a low O2 saturation because they're not getting blood from the right side of the heart to the left side of the heart very well. So when we put an O2 sat monitor on, we see that the blood is poorly oxygenated, okay, because of the fact that it's just not pumping very well from the right ventricle. And that's going to cause cyanosis, right? Bluish lips, bluish tinged nail beds. Enlarged liver, I mentioned, and with an enlarged liver, you have problems getting the blood back from the small intestine because the liver is blocked or engorged with blood, and that's why they have anorexia, loss of appetite, a fullness after they eat. Distended neck veins, again, just has to do with inability of getting blood back to the right side of the heart. And, of course, peripheral edema. Same reason, okay? So we give them oxygen therapy. We monitor their gastrointestinal symptoms, all because of that hepatomegaly and poor blood flow return from the small intestine. A lot of these patients have to go home on home oxygen, right? They're often hypoxemic. Okay, so let's do the questions at the end of the chapter. So number 1, a nurse is providing discharge instructions to a client with COPD and a new prescription for albuterol. Which of the following statements by the client indicates an understanding of the teaching? This sugar can increase my blood sugar. This medication can increase my blood sugar levels. No, that's glucocorticoids, such as prednisone. This medication can decrease my immune system. No, that's glucocorticoids as well, such as prednisone or methylprednisolone. I can take an increase in my heart rate while I can have an increase in my heart rate while taking this medication. Yes, it's a beta-2 agonist. It's going to cause tachycardia. I can have mouth sores while taking this medication. No, that's more commonly the glucocorticoids because they can cause thrush and oral ulcers. Okay, so the answer is C. Number 2, nurse is preparing to administer initial dose of prednisone to a client who has COPD. So prednisone is oral. The nurse should monitor for which of the following adverse effects. So hypokalemia. Okay, so let's just get this straight. So corticosteroids have a steroid ring. Okay, that makes sense. They're steroids. They have a steroid ring. Aldosterone, which is a hormone in your body, has a steroid ring. So what does aldosterone do? It reabsorbs sodium and gets rid of potassium. And by the way, it also reabsorbs water. Okay, so what's cortisone going to do since it's similar in shape to aldosterone? Reabsorb sodium, reabsorb fluid, and decrease and get rid of potassium. And that's why you're going to have fluid retention with corticosteroids, and you're going to have hypokalemia with corticosteroids. So A is correct. B is with beta-2 agonists, so not with corticosteroids. C is correct, fluid retention, right? You're reabsorbing salt or sodium and fluids. D, nausea. Well, that's not a fair one. Corticosteroids upset the stomach and can cause nausea, so I think that one should be correct. I think they're trying to get at the fact that beta-2 agonists also cause that. I don't agree with that not being included. Black tarry stools from peptic ulcers and bleeding ulcers from the corticosteroids. So A, C, and E. I think D is correct as well, if you chose that. A nurse is discharging a client who has COPD. The client is concerned about not being able to leave the house due to the need for staying on continuous oxygen. Which of the following responses should the nurse make? There are portable oxygen delivery systems that you can take with you. Absolutely. Lots of portable oxygen systems so you can go out. So that's going to be the answer. When you go out, you can remove the oxygen. No, that's not a good idea. You're going to become hypoxemic. C, you will probably not be able to go out as much as possible. That's not true with the portable devices. D, home health services will come to you, so you will not need to go out. No, that's not accurate. You can still go out. So A is the answer. 4, a nurse is instructing a client on the use of incentive spirometer. Which of the following statements by the client indicates an understanding of the teaching? So an incentive spirometer is to encourage you to take deep breaths to avoid atelectasis or to avoid a post-op pneumonia, right? It keeps the alveoli opening, especially if you do it every hour. So A, I will place the adapter on my finger. No, that's an O2 sat monitor. That's not an incentive spirometer. I will lie on my back with my knees bent. No, that's not, no, you wouldn't use an incentive spirometer lying on your back with your knees bent. I will rest my hand over my abdomen to create resistance. No, that's not part of the use of an incentive spirometer. That would be an abdominal or a breathing exercise. I will take in a deep breath and hold it before exhaling. Yeah, you're trying to keep that ball that's in the incentive spirometer at the top. It's encouraging you to take a deep breath, right? So D is the answer. 5, last one. The nurse is planning to instruct a client on how to perform pursed lip breathing. Which of the following statements should the nurse include? Take quick breaths upon inhalation. No, pursed lip breathing is about exhaling here. Place your hand over your stomach. Okay. Take a deep breath in through your nose. Okay, so that would be part of pursed lip breathing. Okay, to control your breathing and bring it in through your nose, and then when you exhale, you're doing a different technique. I don't really agree with this answer either. So pursed lip breathing is where, sure, you're slowing down your breathing so you can breathe through your nose, and then after you've inhaled, you pucker your lips a bit. Okay, not your cheeks, but your lips, and you make the hole where your mouth is smaller by puckering your lips a bit, and it creates some back pressure into the lungs by letting the air out a bit slower. That's called pursed lip breathing. Okay, so I don't really like the answers here. It's basically you breathe in slowly through your nose. Okay, that's fine. So that's the only answer here. Breathing in slowly through your nose. But the pursed lip part is really when you exhale, that you pucker your lips a bit. Okay, so because that's the only good answer here, because you don't puff out your cheeks, you take a deep breath. You take a deep breath in through your nose. That's the only correct answer. Okay, let's move on. Okay, so let's talk about tuberculosis a bit, which is an infectious disease of the lungs caused by Mycobacterium tuberculosis. Okay, so how is it transmitted? Through small droplets, so we'll call airborne route, right? So it's from people coughing and releasing Mycobacterium into the air, okay? And then once it's inhaled into a lung, it actually forms these granulomas of infected tuberculosis. And then other cells kind of try to surround it with inflammation. Okay, so often we'll see them as these round nodules on chest x-ray. Okay. Most of the people that have been in contact with someone with TB, most people won't develop active TB. They may develop latent TB, meaning they've been in contact with someone with tuberculosis and they'll test positive when we do a skin test for tuberculosis, but they won't have any symptoms. So that's called latent TB. A small percentage of those people will then develop active tuberculosis. Okay? Remember, tuberculosis typically affects the lungs, but can actually spread to lymph nodes, kidney, adrenal glands, and infect those organs as well. Okay? Now, anyone who lives in a high-risk situation should have annual TB skin tests, right? So, for example, family members of a patient who has tuberculosis should be screened for latent TB. Even if they don't have symptoms, they might have latent TB, and we treat latent TB with isoniazid. Okay, so who else would be at higher risk for TB? So patients that are coming from developed countries or from countries that are endemic with tuberculosis, they're at higher risk for either having latent TB or active TB. Okay, so when you get TB, it's typically a slow onset. Okay, and often it's latent for years. You don't have any symptoms. But even when you do develop it, it's typically a slow onset of coughing, some shortness of breath. You might start to lose weight. You're not hungry anymore. Coughed up a bit of blood. Some night sweats, chills. It's becoming a chronic respiratory condition. Okay. What else can I tell you about tuberculosis before we move on? I think just to remember that most people that are TB positive are on skin test. Remember, they don't have active TB. They have latent TB. And they have a chance of developing active TB as they get older, or if they were to become immunocompromised. Okay, let's just talk about some risk factors for acquiring TB. So definitely frequent and close contact with patients that are not treated. Okay, so so family members of someone with active TB, not latent TB. You're not contagious if you have latent TB. Okay, patients in a homeless situation where they're going to homeless shelters, crowded conditions, increased risk of TB. Immunocompromised patients, chemotherapy agents, HIV, bone marrow diseases, diabetes. Anyone who's having to take immunosuppressant drugs is at risk for TB. Areas that are extremely crowded, such as prisons, long-term care facilities that have a lot of people aggregated together. Advanced age is a risk factor for developing active TB, especially if you had latent TB, and then your immune system starts to get weak and you develop active TB. Traveling outside of the United States to endemic areas, so parts of the world that have a lot of TB. Immigration into the US from a number of countries that have tuberculosis. Okay? And of course, healthcare occupations. That involves treating patients, especially with respiratory disorders. Okay? So this slide is showing you, well, first it's mentioning that tuberculosis is through aerosolization from infected patients with active TB, right? And it's airborne. So, so early detection is really important because we can pick up patients with latent TB that have no symptoms and early TB as well, right? So people living in high-risk areas and all those risk factors that I mentioned to you, people living with members, people living with someone who has active TB should be screened. So when someone is screened, it doesn't mean they have any symptoms, right? So the screening is the TB skin test, and if it's positive and you don't have symptoms, well, you have latent TB. You're not infectious, but you may benefit from receiving isoniazid to clear the latent TB, okay? Because it can become activated later in life as the immune system starts to weaken, okay? So the symptoms at the bottom, we've already spoken about. All of those are extremely common symptoms with tuberculosis, okay? Now, when we're talking about testing, There's a couple of tests, one on the sputum and one in the blood that gives us rapid results. So there's one called the nucleic acid amplification test, and we get a good sputum sample, and we can test within the sputum if there's any evidence of tuberculosis. Okay, so and a result can come back very quickly, within hours. Okay, the quantiferon TB Gold test is a blood test, and what are we looking for? Well, it's a test that we take, and we're looking for evidence of tuberculosis, whether it's active or latent. Okay. Now remember, not everyone can give a sputum sample, so the first test may not be possible. A nucleic acid amplification test. You need to be making phlegm. Okay. The other one is a blood test, so latent or active TB can be checked for. Acid-fast bacilli test is a test where we're going to get a sputum culture, but it can take a long time for the tuberculosis to grow. Now, someone who has an acid-fast bacilli culture from a sputum sample typically will have active infection. Okay. Again, it can take weeks to obtain the results. So we get early morning sputums, and we send them off to culture. I mentioned that tuberculosis is a slow-growing mycobacterium, so we don't get results for weeks. What about the TB skin test? So this is really a screening test, right? So typically, someone who's been exposed to tuberculosis, they're typically going to have a positive TB skin test, which is a little intradermal injection of tuberculin, in the range of weeks to months after their exposure, right? So what we do is we inject a bit of the tuberculin on the inside part of the forearm, and we wait and read it 48 to 72 hours later, 2 to 3 days later. And we're looking for induration, meaning raised skin, the area, the circle of raised skin, not the redness. It's the circle of raised skin. So an induration of 10 millimeters or more indicates a positive test usually. Okay. In immunocompromised patients, we accept 5 millimeters of induration because they don't mount the same response. So even 5 millimeters is enough to call it positive if you're immunosuppressed. Okay. So what does the MAN2 test tell us? It tells us that the patient has developed an immune response to TB in the past, and we're picking it up by the TB skin test. It doesn't tell us if there's active TB. That would be based on symptoms. Latent TB doesn't have any symptoms. It just means that it's living in your body. Okay? Now, a patient who's had a TB vaccination in the past, called BCG, Bacillus Calmette-Guerin vaccine, so they've had the vaccine and now we're giving them a TB skin test. They may respond and get a positive TB skin test based on the fact that they had a vaccine years ago. Okay, so it may not be very useful to do a TB skin test on someone who's had the vaccine in the past. And then we just go to a chest x-ray or a blood test. Okay. Some patients that are severely immunocompromised just don't generate a positive result even if they have latent TB in their body, because they're so immunosuppressed they don't respond to the tuberculin that we've injected under their skin. Okay. Just making sure I cover some of the points here. Okay. So we often get people returning to have their TB skin test read 2 to 3 days later. Okay, so they they've had it done, they return, and then we see if there's a response. If we see there's a response, we'll measure it to see how much of induration is there. Remember, it's not the redness, it's the induration. Okay, so I'll just continue talking about tuberculosis diagnosis. The Mantoux skin test is what we were just talking about. It's intradermal. It's red 48 to 72 hours after the injection on the inner forearm, and it's measuring the induration. Okay, 10 millimeters positive. If you're immunosuppressed, we'll accept 5 millimeters. Okay. The quantiferon TB gold blood test we spoke about. Let's go on to chest X-ray. So chest X-ray would be for someone who had a positive TB skin test. Okay, that doesn't tell us anything about whether it's latent or active. It's just one of them. They tested positive. We can go on and have a chest X-ray to see if there's any signs of active tuberculosis in the chest. Okay, the acid-fast bacilli I mentioned. That, if it's positive, is really suggestive that you are growing mycobacterium in your sputum, and that's suggestive of active disease. Okay. Now, just as a reminder, there are some patients who are going to either be immunocompromised, so say HIV patients, or they're going to receive treatment that's going to make them immunocompromised. And there's many drugs that can make you immunosuppressed. So often a TB skin test or a TB test is required before receiving the treatment to see if you have latent TB that could become activated from the treatment. Okay, this slide I won't spend too much time on. Heated and humidified oxygen therapy for tuberculosis, airborne precautions, since it's an airborne transmitted disease, so negative pressure room, an N95 respirator. Patients will have to wear a mask when being transported out of the room. Adequate nutrition. Why? Again, because the body's treating an infection, right? So you need proper nutrition. Okay, I think that's all I'm going to say on this slide. We'll just keep on moving because I know there's quite a few slides left. Okay, so let's just look at this slide for a bit. So the importance of educating the patient on taking their medications regularly and the same time each day, especially regularly, right? You're trying to treat an infection that's requiring sometimes 3 or 4 drugs. And that's because tuberculosis is becoming resistant. So if you're not taking your medications regularly, it's going to give the tuberculosis some time to start to reactivate and grow and divide again. Okay, so really important to adhere to the medication regime. Wearing a mask in public areas. Otherwise, if you have active TB, you're going to be coughing mycobacterium onto surfaces and potentially infected other patients. Reporting of jaundice, because a lot of these tuberculosis medications are hard on the liver, right? And it can lead to jaundice. And that's why we don't recommend alcohol use either, because of the risk of these drugs causing hepatitis, and of course alcohol can cause alcohol hepatitis, right? Often the length of time to treat tuberculosis is 6 to 12 months, even up to 2 years with resistant tuberculosis. Okay, so in terms of the medications, why do we combine 3 or 4 medications for active TB? Because of increasing resistance, right? And it takes a long time to treat tuberculosis, 6 to 12 months, right? So non-compliance is a really big problem, and it can create resistant tuberculosis strains, okay? So the typical, 4 drugs that are combined: isoniazid, rifampin, pyrazinamide, and ethambutol. Okay, And in the book, it'll give you some important information about each drug. Just to say, isoniazid is the drug that we typically use for latent TB by itself. Okay, so a patient will take isoniazid. They don't have any symptoms. They test positive, so they have latent TB. And what we want to do is prevent developing active TB later. What's the main symptom of isoniazid? They can develop a peripheral neuropathy. Okay, it says neuritis there. That's a bit of an odd term. So peripheral neuropathy. And we can reverse the peripheral neuropathy with vitamin B6. Okay, which is also called pyridoxine. So isoniazid is a very important drug because it's part of treatment of active TB, but also it's the drug that we use for latent TB as well. Okay, it's also hepatotoxic. So not only can it cause a peripheral neuropathy, it can cause hepatotoxicity as well. I would just choose the main side effect of each drug and remember it. Isoniazid, peripheral neuropathy, and hepatitis, right? Let's look at rifampin. Rifampin is going to turn your urine orange, and it can also cause a hepatitis. Okay, so orange, yellow with rifampin, and the potential for hepatitis. Okay, pyrazinamide. What can that do? Well, it's hard on the kidneys, right? And it can also cause gout. So, we check. It's hard on the liver and the kidneys. So we check for hepatotoxicity with pyrazinamide, and we can also advise on the fact that it can increase the incidence of gout. Okay, and ethambutol, the main issue there in terms of adverse effects is vision. Okay, so they'll need visual acuity tests, and they'll need follow-up to monitor for reduced vision. Okay, so every drug, there's going to be one or two side effects that you should probably just keep in mind. Streptomycin, it's going to be ototoxic, so I would think of that. Well, it is an aminoglycoside. Aminoglycosides in general are hard on the kidneys and hard on the ears. Okay, so that's why they're mentioning ototoxicity here. Okay, so let's just briefly talk about client education and we'll do some questions. So TB is definitely usually treated in the home setting with follow-up. Airborne precautions aren't needed in the home because everyone's already been exposed, right? So it's not like everybody has to wear a mask at home. Okay, family members should be screened for TB, and if they have latent TB, they can be offered treatment with isoniazid. Right? Treatment is usually 6 to 12 months. They need to monitor for symptoms of hepatitis, such as anorexia, nausea, jaundice. Sometimes they need to be treated up to 2 years for multi-drug resistant TB. Not taking your medications regularly will result in resistant strains of TB. Okay? Sputum samples are usually needed typically every 2 to 4 weeks to monitor for drug effectiveness, right? And if you no longer are culturing any mycobacteria in the sputum on 3 consecutive visits, then you are assumed not to be infectious any longer, okay? I think that's it. Wearing a mask in public places is always a good idea. Now let's go to complications. Miliary TB just means that the TB has spread from the lungs elsewhere into the body. Okay, so it can spread to multiple areas of the body. Lymph nodes. It can spread to the kidneys, all over the place. So that's all miliary TB is. Okay, so and the treatment would really be the same as for respiratory TB or pulmonary TB. Okay, let's look at the questions here. A home health nurse is teaching a client who has active tuberculosis and is following a medication regime that includes a combination of isoniazid, rifampin, pyrazinamide, and ethambutol. Which of the following client statements indicates understanding? I can substitute one medication for another if I run out. No, that's a bad idea. Um, that's not going to help with fighting resistance. I will wash my hands each time I cough. Absolutely, because you may have mycobacterium in your hands on your hands now. I will wear a mask when I am in a public place. Very good idea to avoid spreading the disease. I am glad I don't have to have any more sputum specimens. That's not true. They typically need sputum specimens every 2 to 4 weeks um, until they're not infectious. I don't need to worry where I go once I start taking my medications. No, you have to be shown to be non-infectious first, right? So until then, they should be concerned about where they go. Okay, so the answer is B and C. Number 2, a nurse is teaching a client who has tuberculosis. Which of the following statements should the nurse include? You will need to continue to take multi-medication regime for 4 months. No, it's typically longer than that, 6 to 12 months, up to 2 years. You will need to provide sputum samples every 4 weeks to monitor the effectiveness of the drug. That is correct, because we want to see if the sputum cultures become negative, right? Which is a good sign. You'll need to remain hospitalized for treatment. No, you can go home typically with TB, unless you're very ill. You'll need to wear a mask at all times. No, you won't. In particular, at home, you wouldn't need to wear a mask. A nurse is caring for a client. So number 3. For number 2, it's B. A nurse is caring for a client who has a new diagnosis of tuberculosis, has been placed on a multi-medication regime. Which of the following instructions should the nurse give the client related to ethambutol? So this is where you should know about your adverse effects, right? So the first one, dark orange urine, that's going to be rifampin. Watch for a change in the sclera of your eyes. Well, that could be a lot of them, right? Pyrazinamide, isoniazid, not so much ethambutol, okay? It's going to be vision somewhere. Watch for any changes in vision. There you go. That's ethambutol. Take vitamin B6 daily. No, that's isoniazid. Okay, so it's C. 4, a nurse is preparing to administer a new prescription for isoniazid to a light-skinned client who has tuberculosis. The nurse should instruct the client to report which of the following findings as an adverse effect. You might notice yellowing of your skin. Okay. So isoniazid does have the potential for causing jaundice, so I'm not sure why they didn't mention that. They've put that one. You might experience pain in your joints. No, that one's not. Which drug are we looking at here? Isoniazid, yeah. So B, that one's not accurate either. You might notice tingling of your hands. So there's the peripheral neuropathy of isoniazid. Okay, so C is correct. I still think A is fair though. And D, you might experience a loss of appetite. I think that can happen with any drug, so I don't really see that as a fair statement. So the one that's closest to the truth, and the one that's definitely accurate, is tingling of your hands, paresthesia. But you can get some jaundice with isoniazid, so I think A is also correct. So, yeah. Number 5. A nurse is providing information about tuberculosis to a group of clients at a local community center. Which of the following manifestations should the nurse include? Persistent cough? Absolutely. It's a chronic persistent cough. Weight gain? Nope. They're losing weight. Fatigue? Absolutely. They're fighting an infection. Night sweats? Absolutely. Right? They have an infection, they're developing fevers, in particular at night. And purulent sputum, that can definitely happen with tuberculosis as well. So, okay, so it's A, C, D, and E. Okay, let's move on. Okay, so let's move on to the next chapter on pulmonary embolism. And pulmonary embolism is where a fragment or a piece of either air or tissue, blood clot has traveled. It's embolized to the lung, and in particular, it's embolized to a pulmonary vessel, right? Because that's how it got there. It traveled typically through the venous system. So there's other less common ones, such as air emboli, say from a syringe that we're using, and by mistake we put air into the venous system or an IV tubing, and we give an air embolus to the lungs. There's septic emboli, such as if someone has infective endocarditis, so bacteria and clot on a valve in the heart, and if it breaks off and travels to the brain, you could have a septic emboli to the brain. There's amniotic fluid emboli, where some amniotic fluid gets into the venous system and travels to the pulmonary system. There's fat emboli from a long bone fracture. So the bone marrow is full of fat, and that can travel in a fracture to the venous system and then get into the lungs and cause a fat embolism. But in general, we're typically talking about venous thromboembolism. So a blood clot in a vein, most often in one of the legs or in a pelvic vein, and a piece of the DVT breaks off, travels to the heart and then the lung, and blocks one of the pulmonary arteries or pulmonary vessels in the lung, causing a PE. Okay, so let's move on and talk about risk factors, treatment of this condition. It's not an uncommon condition, especially in elderly and especially in people that are on certain medications, such as estrogen. Birth control pills is a risk factor, but we'll get into all the risk factors. Okay, risk factors for developing a pulmonary embolism. Well, they're going to be the same as the risk factors for developing a deep vein thrombosis, right? Because that's where the PE came from. It typically broke off um, a clot in your leg or your pelvis and traveled to the lungs. Okay, so risk factors are the same. So what are the risk factors for either a DVT or, if a piece breaks off, a PE? Long-term immobility. So if you're lying in bed for a long time and you're immobile, the chance of you forming a DVT because of poor venous return in the legs is high. Okay, so definitely a risk factor, and we address that particular risk factor, in particular post-operative patients that are going to be lying in bed for a prolonged period of time, because it's such a known risk factor. Oral contraceptives with estrogen in them. So estrogen tends to thicken the blood, leading to DVTs and then, of course, PEs. Pregnancies, you have higher level of estrogen. And you also have typically decreased venous return because the developing fetus is starting to put pressure on the pelvic veins. And you can get leg swelling and decreased venous flow from the legs, right? So not only do they have more estrogen, but they have decreased venous flow. Tobacco use, well, cigarettes thicken the blood. Okay, so the chemicals in cigarettes thicken the blood, leading to DVTs and PEs. Obesity is a risk factor because of poor flow in the legs, right? So if you were to bend your knees or sit in a chair, you'll notice that your hip is bent. So the vein's going to be kinked. That's why we tell people that are flying long distances to get up every hour, or at least at a minimum, move your legs frequently. Okay, so obesity is a risk factor because of the decreased venous flow in the legs. Surgery is due to immobility. Okay, lying down, spending a day, 2, 3 days post-op, and there's decreased venous flow. Heart failure. Well, heart failure is a risk factor because if you have heart failure, there's less blood that's able to return to the heart because of the heart failure. So it's backing up into the legs, right? So with that slower, sluggish return of blood comes an increased risk for DVTs and PEs. Advanced age, purely because of potential immobility, damage to the veins over the years. Cancer is a risk factor that you shouldn't forget for PEs and DVTs. So anyone with a history of cancer has a higher risk of developing a DVT or a PE. Anyone with a hypercoagulable state, meaning someone who has really elevated platelets, well, they're going to have thicker blood, right? I mentioned cancer, and I really don't want you to forget that one, because anyone with any form of cancer, cancer tends to thicken the blood and increase the risk of DVTs and PEs. Okay. Any trauma. Why trauma? Well, if you have trauma to the legs, you may have injured the vein, and an injured vein is more likely to clot. And there's a term that we use called Virchow's triad. So Virchow's triad. Okay. And Virchow's triad basically is just reminding you of the 3 factors that predispose you to developing a DVT. So anything that injures the vein is one corner of the triangle. Okay. So any trauma, anything that has previously injured the vein, such as a previous DVT, puts you at risk for another DVT. Okay, let's look at another corner of the triangle. Hypercoagulable state, increased platelets, cancers make your blood thicker, cigarette smoking, estrogen, pregnancy. Okay, that's another corner of the triangle. And the last corner of the triangle would be decreased venous flow, so venous stasis. So if you're not moving very much, if you have a fracture and you can't move that leg, anything that reduces venous return, again, another one is heart failure, decreased venous return, right? So if you think of those 3 parts of a triangle, hypercoagulable, anything that makes your blood thicker, anything that damages the vein, and anything that reduces venous flow, then you're going to have all of the risk factors for DVT and PE. Okay, so let's look at the expected findings. And let's just think about this for a minute before we go through all these. So someone comes, someone has a DVT and a piece breaks off and travels to the lung. That's going to be a pretty sudden event. Okay, so most people that we see have the sudden onset of shortness of breath, pleuritic chest pain, meaning when I take a breath, it really hurts in my chest because it's stretching the pleura that's been damaged from the blood clot. Okay, so shortness of breath, pleuritic chest pain, they can be hypotensive, tachycardic, okay, because the heart is now having to pump more because it's trying to get around this blockage through other vessels in the lungs. Okay, let's look at, so that's the typical way that they present, but let's look at some of these. So anxiety and impending doom, well, that's because of the shortness of breath. Okay, there's been a sudden blockage in one of the pulmonary arteries, which is causing shortness of breath, or sorry, anxiety. Pleuritic chest pain would be the next one. I take a big breath and it hurts. Okay, and there it is, pain on inspiration. Okay, pleuritic chest pain. Dyspnea and air hunger, that's just shortness of breath. Some people with PEs can cough up blood, right? They've blocked an artery in the lung, and some of the lung tissue after the artery is dying. So they're coughing up some blood. Tachycardia. Okay, there's blockage of blood flow to the left side of the heart. So the heart says, I have decreased cardiac output. I better beat faster. Okay, so tachycardia. Hypotension can happen because of less blood going to the left side of the heart. Tachypnea is just breathing fast. Decreased oxygen saturation because the blood is now blocked from going to a portion of the lung that had air there. So it has to go around there and get back to the left side of the heart. So they can have decreased O2 sats because deoxygenated blood is getting back to the left side of the heart. Petechiae, that would only be with a fat embolism. That wouldn't be common with a venous thromboembolism. Okay, so that one I would just reserve for a fat embolism. Distended neck veins. Well, if you have a massive PE that's blocking your pulmonary artery, meaning your right ventricle can't pump because there's a big clot in the pulmonary artery, well, everything backs up, and your neck veins, the blood in your neck veins can't drain back to the right ventricle, right? So they're distended. Cyanosis is hypoxemia, right? Decreased O2 sat. Okay. Okay, let's look at ways of diagnosing a pulmonary embolus. Okay, so someone comes in with shortness of breath, pleuritic chest pain, anxious, maybe coughing up a bit of blood, and we want to see if they have a pulmonary embolus. Okay, so we can order an arterial blood gas. How's that going to help? It's definitely not going to diagnose a pulmonary embolus because even if it's abnormal, many things can cause it to be abnormal. So on the blood gas, they may be hypoxemic. Initially, if someone's breathing really fast, they may have a low CO2 because they're breathing fast, they're blowing off their CO2. But if it's a really large pulmonary embolus and it's clotting up a lot of the lung, they're going to have difficulty breathing gradually and more difficulty, causing backup of CO2 and a respiratory acidosis. So because the CO2 has gone up. So initially it can go down because they're breathing fast, but with large blood clots, they're having more and more difficulty breathing. The CO2 is going to go up and they're going to get respiratory acidosis. Not an accurate test for PE though. A D-dimer is basically a blood test that shows us if there's active clotting going on in the bloodstream. So we could order a D-dimer test. It's not confirmatory though. It just tells us that something odd in the blood clotting of the body is going on. So if it's elevated, we need to go on to a diagnostic test, a confirmatory test. And that would be a CAT scan with dye. So we inject a bit of dye into the vein, we wait for it to travel to the lungs, and we do CAT scan of the lungs. And that's typically the way that we diagnose pulmonary emboli, with a CT scan with dye, what's called a CTA. Okay, chest x-rays. We'll do a chest x-ray, but we'll never diagnose a PE on chest x-ray. They don't show up on chest x-ray. Sometimes we can see maybe a bit of possible evidence that something looks strange on the chest x-ray, but we can't confirm it with a chest x-ray. Okay. A VQ scan is a very old way of diagnosing PEs. We really don't use it anymore. But it would be a scan where we would see where the air is traveling in the lungs. So that's the V, the ventilation. And at the same time, we would see where the perfusion is traveling in the lungs, and that's the Q. Okay? And where the air is traveling in the lungs and where the blood is traveling should be very similar. If there's a blood clot, meaning a PE, the Q, so the perfusion will be altered because there's a blockage, and it'll be an abnormal VQ scan. We don't use them very much anymore. They're not as accurate as a CTA. Lastly, pulmonary angiogram, where we put a catheter into the vena cava, and then we squirt dye that travels through the lungs, the arteries of the lungs. Yes, it's very accurate, but we don't use it very often because we have a CT angiogram that we can use, which is less invasive. Okay, a pulmonary angiogram, angiography is more invasive. Okay. Okay. Now, just like any other disease, pulmonary emboli have a spectrum of disease. You can have a small pulmonary embolus that's just giving someone a bit of pleuritic chest pain and some mild shortness of breath, and we diagnose it with a D-dimer followed by a CTA, and we treat them with anticoagulants. Okay. What does the anticoagulant do? It doesn't break up the pulmonary embolus. So the part that's traveled to the lung already, the body's going to break it up. What an anticoagulant does is it stops further development of the DVT. And by doing that, it prevents breaking of another piece that's going to travel to the lung. So the piece that's traveled to the lung already, there's not much we're going to do for that. Okay, it's going to break up on its own. The body's going to do that. We can definitely provide oxygen. We can definitely provide fluids if they're hypotensive. And I'm going to talk to you about one particular treatment that we sometimes do in a massive PE. But other than that, think of the anticoagulants as preventing further PEs from developing due to an extending DVT, okay, because that's their role. So we can use heparin. Heparin's usually given IV for a DVT. So it's a bit onerous because now the person has an IV. We're having to check PTTs frequently. We can use a low molecular weight heparin, such as enoxaparin, which is just weight-based, and we don't need to check a PTT, right? So they're much easier to use. They give predictable anticoagulation. Okay, we can start someone on warfarin. Remember, warfarin can take 3, 4, 5 days to become therapeutic. So while we're waiting for warfarin to become therapeutic, they need to either be on heparin or enoxaparin because they work right away, right? So the anticoagulant effect of heparin and enoxaparin work right away. Sure, we can start them on warfarin knowing that it's going to take 3, 4, or 5 days for the warfarin to take full effect. And once it takes full anticoagulant effect, we can stop the heparin or the enoxaparin and continue on with warfarin. Okay? Or we now have direct factor inhibitors. So, for example, rivaroxaban, or another one called apixaban. Those are medications that directly inhibit factor 10A in the clotting cascade, and they work immediately. So if someone comes in with a PE and we want to start rivaroxaban or apixaban, we don't even need to bridge them with heparin or enoxaparin. They start working right away. And that's why these drugs have become so popular, because we don't need to bridge them with heparin or enoxaparin while waiting for them to work, which is what we have to do with warfarin. Okay. Now, thrombolytic therapy. So there's some evidence that if someone has a massive PE, so a huge clot has traveled to the heart and then blocking the pulmonary artery, so there's very little blood that can leave the right ventricle to get to the lungs. So the person's going to be in big trouble. They're going to be hypotensive, tachycardic, respiratory distress. They're in big trouble. There is a thrombolytic we can use, so TPA, that we can squirt into the vein, into a vein that's going to travel to the heart and then travel to the massively clotted pulmonary artery and try and break up the clot. Okay, that's fibrinolytic therapy for a PE or thrombolytic therapy. Okay, when I was talking about anticoagulants, that was to prevent the DVT from breaking up another piece and traveling to the lung. The thrombolytic therapy is meant to try and break up a massive PE. I don't want you to get the idea that we use thrombolytic therapy very frequently for a PE, because we don't. Okay, but it's a kind of a Hail Mary when someone has a massive PE and we don't have anything else to offer, and we want to try and break up the clot in the lung. Okay. Now, what else can we do if someone's getting repeated PEs? So they're on blood thinners for their DVT, but they continue to send PEs to the lungs. Well, we could put a filter in the inferior vena cava. So the filter gets inserted. It's almost like a protective filter. So when a clot travels up from the leg, the filter stops it. Okay, it doesn't let it get to the heart. Okay, so that's called an IVC, inferior vena cava filter. What else could be done? Again, this is a bit of a Hail Mary, but if someone comes in with a massive PE, okay, we could try TPA, so that thrombolytic therapy, or they could be rushed to surgery and see if an embolectomy is possible, where they open up the chest, get into the pulmonary artery, and see if they can get that massive clot out. Okay, not very common. Again, it's something that's sometimes offered as a last-ditch effort to try and save the person. Okay. In general, the treatment for PEs is maintaining oxygenation, maintaining blood pressure, and some form of an anticoagulant. So remember, if someone starts on heparin, how do we follow the blood thinning effect of heparin? PTT. If someone is started on enoxaparin, how do we follow the blood thinning effect of enoxaparin? We don't need to. It's weight-based. So nice and simple. Warfarin, so that inhibits vitamin K-dependent clotting factors from the liver. We use INR, right? INR, or the older one, PT, prothrombin time. We use INR much more frequently now. It should be between 2 and 3 if it's therapeutic. Okay. How do we monitor direct factor 10A inhibitors for their blood thinning effect? We don't need to. Okay, they have a fixed dose, and there's no need to monitor them, which is awesome. What do we care about the most with all of these anticoagulants and antifibrinolytics? Bleeding. We need to monitor for bleeding, right? And we need to ask about bleeding conditions before giving them. So, have you had a gastrointestinal bleed? Have you had a recent stroke? Have you had recent surgery? We want to know all those things because that's going to increase their bleeding risk. Once we administer them, we want to tell them. If you have bleeding in your gastrointestinal system, such as melena or vomiting blood, or excessive bruising and bleeding, you need to let us know. Okay? So all these anticoagulants, it's always the same thing. It's all about bleeding risk. Okay? Okay, so remember, most pulmonary emboli originate from a DVT, right? And the risk factors can easily be remembered if you remember Virchow's triad, right? One corner of the triangle, hypercoagulability states. So estrogen, smoking, cancers, things like that. Another corner, decreased venous return or venous stasis. That's immobility, obesity, congestive heart failure, anything that's slowing down the blood flow back to the heart. Okay? And injury to the vein. So a trauma to the leg, a crush injury to the leg, a previous DVT, anything like that that's injured the vein in the past can lead to development of a DVT. Okay, Vircho's triad. Okay, so patient education, so decreased clotting factors. So how can we decrease the clotting risk? Well, smoking. Smoking thickens the blood, right? So education about quitting smoking and potentially treatment about for quitting smoking. Avoiding prolonged periods of immobility. So if you're on a flight for 10 hours, say you're flying to Canada, that's not 10 hours, but say you're flying to Canada. Getting up every hour, moving your legs so that there's venous flow, right? Remember, when you're sitting on an airplane, your knees are kinked and your hips are kinked. So there's decreased venous flow, okay? So avoiding prolonged periods of immobility. And the same thing would go for avoiding crossing the legs, because what are you doing? You're kinking a vein. And remaining well hydrated. If you're well hydrated, you're keeping the venous flow very good, right? If you're dehydrated, the venous flow is slowing down, the blood's getting sluggish, right? And venous stasis is a risk factor for getting a DVT. Now, if we were to use warfarin, which inhibits the vitamin K dependent factors in the liver from being produced, we typically tell people just continue on with your regular diet. So if it's someone that eats lots of green leafy vegetables and that's their regular diet that they're going to continue for the next 20 years, that's fine. We can adjust the warfarin based on your diet. But if suddenly someone that's taking warfarin starts eating lots of vitamin K in their diet, it's going to decrease the effect of warfarin because vitamin K is the reversal agent for warfarin. Okay, so we adjust warfarin based on someone's diet, but we want to know if they're changing their diet so that we can monitor their INR, and we may need to adjust the dose of warfarin. Okay, so monitoring of INR is at the longest 1 month. At the beginning, it's typically a few times a week while we're adjusting the warfarin dose to make sure that we're not getting too thin in the blood, and that would mean an elevated INR. So if someone has an INR of 5, that means their blood is getting really thin, and sometimes we have to give people a dose of vitamin K just to thicken their blood a bit more, get it back between 2 and 3, which is where we want the therapeutic dose of warfarin to be. Okay. We warn people about the risk of excessive bruising, GI bleeding, melena, anything like that while they're on warfarin because we want them to report back to us. Okay. Sometimes somebody's INR can become very high, dangerously high, and they need to report the excessive bruising and bleeding, and we'll check an INR. And if it's higher than 3, we may need to adjust their warfarin and give them a bit of vitamin K to decrease the INR that day. Okay, so let's do the questions at the end of the chapter on pulmonary emboli. 1, a nurse is caring for a group of clients. Which of the following clients are at risk for a pulmonary embolus? A client who has a BMI of 30. So 30 would definitely be overweight. So overweight and obesity is a risk factor for PEs. Why? Decreased venous return. So obesity causes more kinking at the knee and the hip. And obesity, by the way, you typically produce more estrogen. Fat cells make estrogen. That thickens the blood. Okay, so that would be an answer. That would be a correct answer. B, a female who is postmenopausal. No, that shouldn't be a risk. That shouldn't be a risk factor because, in actual fact, she's not even making estrogen anymore. So there's no risk factor there. A client who has a fractured femur, absolutely, they're going to be immobile. And on top of that, they've had an injury to the leg, and they've possibly injured the vein. So there's 2 corners of Vircho's triad, right? an injury, so a venous injury potentially, and immobility, and that's decreased venous stasis, right? So trauma and venous stasis, increased risk of PE there, and DVT. A client who is a marathon runner, no, they don't have any risk factors for a PE. A client who has chronic atrial fibrillation. Okay, E, a client who has chronic atrial fibrillation. I think that's a sneaky one. So why would atrial fibrillation be a risk factor for developing a PE? Well, we know that in the left atrium, you can form clots that can then travel to the left ventricle and be pumped out and cause a stroke. Well, let's look at the right atrium. The right atrium could actually form a clot that could travel to the right ventricle, that could then be pumped to the pulmonary system and cause a PE. I think that one's a bit sneaky, but that it is a possibility. So the answer is A, C, and E. 2, a nurse is assessing a client who has a pulmonary embolism. Which of the following manifestations should the nurse expect? Bradypnea is slow breathing. No, they'd be tachypnea. A pleural friction rub. So it is possible to develop a pleural friction rub. Remember, I mentioned that when you get a blood clot, it's blocking an artery to part of the lung, and that can also block supply to the pleura, and it's going to cause inflammation of the pleura. And when you take a big breath, you may have a pleural friction rub. So B would be right. C, hypertension. No, typically they're hypotensive because there's a blocked artery to get blood from the right side of the heart to the left side of the heart, right? So hypotension can occur. Petechiae, this one's a bit, I think this one's a bit mean. This would be more in relation to a fat embolism. Fat emboli, you can get petechiae on your upper chest and neck area. Typically in a pulmonary embolus from a blood clot due to a DVT, you don't usually get petechiae. So I think that one's a bit mean. E, tachycardia, absolutely, right? Fast heart rate because of decreased return of blood to the left side of the heart, and the heart tries to maintain cardiac output by increasing heart rate. So the answer is B, I guess D, and E. Now I'm just going to mention on that question that I really didn't like the answer D, but they're asking, which I think is a bit misleading, a client who has a pulmonary embolus, which of the following manifestations should the nurse expect? Well, usually when you say pulmonary embolus, we're referring about a blood clot traveling from a DVT. But they're kind of using this as any kind of embolus, whether it's a fat or air or blood clot from the legs. So, I mean, I guess in that case, if you include fat embolism, then petechiae would be correct. I still think it's a bit unfair, though. Okay, number 3. A nurse is reviewing prescriptions for a client who has acute dyspnea and diaphoresis. So they're really short of breath and they're sweaty. The client states, I'm anxious and unable to get enough air. Vital signs are 117, so they're tachycardic. Respirations are 38, they're tachypnic. Temperature is 38.4, and blood pressure is 100 on 50. Which of the following nursing actions is the priority? Notify the provider, administer heparin via IV infusion, administer oxygen therapy, obtain a CAT scan. Well, let's go back and look. So they don't give an oxygen saturation, okay? But in situations like this, ABC, right? Just revert back to airway, breathing, circulation, okay? But the problem is they don't give an O2 saturation. So I think that's a bit misleading. But do you need to notify the provider right away? I think it would be done in combination. I don't think it necessarily has to be the first thing. Providing oxygen would be necessary. Giving fluids for hypotension would be a good idea. The person's not terribly hypotensive, but they're breathing fast. They're breathing at 38 per minute. So I guess the answer should be C, giving oxygen. I just don't see an O2 sat, so again, I don't find it an overly fair question. Okay? Because just because you're breathing fast doesn't mean your oxygen is low, but we're kind of inferring it here. Number 4, a nurse is caring for a client who has a new prescription for heparin therapy. Which of the following statements by the client should indicate an immediate concern for the nurse? I'm allergic to morphine. No, morphine's an opioid. Heparin's an anticoagulant. Not a problem. I take antacids several times a day for my ulcer. Ooh, that's concerning. If you have an ulcer and then I give you an anticoagulant, I just may make that ulcer bleed. Okay, so remember, we always ask about bleeding conditions prior to starting anticoagulants. So that one's a concern. I had a blood clot in my leg several years ago. Okay, that's not immediate concern. You're about to get a heparin. You're about to get heparin. It hurts to take a deep breath. I don't think that's an immediate concern. Why? Because they may be receiving the heparin for a pulmonary embolus, right? So they have pleuritic chest pain. It hurts to take a deep breath is pleuritic chest pain. And the heparin is to treat a pulmonary embolus or a DVT. So I think the answer is B here. Number 5, a nurse is caring for a client who is to receive thrombolytic therapy. Which of the following factors should the nurse recognize as a contraindication to the therapy? Okay, thrombolytic, I'm looking for bleeding conditions, I'm looking for severe hypertension, and if I gave a thrombolytic, I might make someone bleed because of the high blood pressure. I'm looking for recent surgery. So, A, hip arthroplasty 2 weeks ago. They had hip surgery 2 weeks ago. That's a definite risk of contraindication for giving a thrombolytic. Elevated sedimentation rate. That's just a test we use for general inflammation throughout the body. So that wouldn't be a contraindication to be giving a fibrinolytic. Incident of exercise-induced asthma 1 week ago. No, that has nothing to do with bleeding or bleeding risk. Not a problem. Elevated platelet count. No, in actual fact, elevated platelet count could lead to clotting, and we're giving an anticoagulant or a fibrinolytic. So that's not a contraindication. So it's definitely A. Okay, so let's talk about pneumothoraxes and pleural effusions. So a pneumothorax is basically a collapsed lung, right? The lung actually is usually adhered to the inner chest wall by the pleura. And if it separates, which sounds pretty painful, and it is, it collapses, causing a pneumothorax. So basically there's air in the pleural space now because the lung has collapsed and separated from the chest wall. If it's a simple pneumothorax, what that means is the air that's in the pleural space is not under pressure, right? Now, could it affect ventilation because the one lung has collapsed? Absolutely. Does it cause chest pain and shortness of breath? Definitely. A complication of a pneumothorax is a tension pneumothorax, where air is continually going into the pleural space and building up in pressure because of a leak from that lung that's collapsed, and more air is going in and it has nowhere to exit. In a tension pneumothorax, the pressure is building up on that side of the chest, and it's going to push everything over to the other side of the chest. Okay, so you're still going to have hyperresonant lung sounds on that side. You're still going to have chest pain on that side. You're going to be short of breath, right? But on top of that, the pressure has moved everything to the other side of the chest, and it's going to block return of blood to the heart because of the high pressure in the thoracic cavity. So what are the signs of a tension pneumothorax? Distended neck veins, tracheal deviation to the unaffected side. Everything's being pushed over, right? Hypotension, again, because there's no blood returning to the heart. Tachycardia, again, because the heart's trying to pump out blood, but it doesn't have enough to pump out because of the tension pneumothorax. Okay, so tension pneumothorax is an emergency. We have to do something right away, and typically we put a needle directly into the pleural space and to release the pressure. Once we've solved the tension pneumothorax, we still have a pneumothorax, and we put a chest tube in and attach it to an underwater seal to resolve the pneumothorax. Okay, so we fix the tension pneumothorax first with a needle decompression it's called, and then we fix the simple pneumothorax that we've converted to with a chest tube. A pleural effusion, just a collection of fluid in the pleural space. And if they're large, what happens is they stop expansion of the lung on that side, and that impedes ventilation, right? So often we need to drain pleural effusions if they're large enough to allow the lung to expand properly. Okay, so if we look at the lower left image, that's a pneumothorax, right? The presence of air in the pleural space, and the lung has fully collapsed, okay? And if that pleural air is not under pressure, we'll call it a simple pneumothorax. How do they present? Sudden onset of chest pain and shortness of breath on one side, okay? And then we can diagnose it with a chest x-ray, seeing the collapsed lung, okay? What's the complication of a simple pneumothorax? A tension pneumothorax. The air has become under pressure and shifting everything over to the other side of the chest cavity, okay? And that's the problem. So just think of the mechanics of what's happening, that high pressure in the thoracic cavity, and you can figure out all the signs and symptoms. Shortness of breath, anxiety, distended neck veins, hypotension, tachycardia. Those are all tension pneumothorax, okay? What's a hemothorax? The top left. It's a collection of blood in the pleural space. So what typically gives you that? An accident or trauma to the chest. And vessels bleed in the pleural space and develop a hemothorax. Okay. What's a pleural effusion? Well, a pleural effusion is just a collection of fluid in the pleural space. That's it. Okay, for whatever reason. Whether it's congestive heart failure or some disease in the pleural space and there's a collection of fluid, is called a pleural effusion. An open pneumothorax is just where you've had something impale your chest and gone through your chest, and it's collapsed your lung, and it's open to the outside world, right? So in that case, we need to seal that hole with whatever bandages or anything to seal the hole, so that air isn't being sucked into the pleural space from the environment. So just keep the different conditions separate. Pneumothorax, collapsed lung. Tension pneumothorax, well, it's a collapsed lung with increased pressure now, causing a whole host of new symptoms. Hemothorax, blood in the pleural space. Pleural effusion, fluid in the pleural space. Okay. What do we do for a tension pneumothorax? We put in a needle directly into the anterior chest to decompress the chest of pressure. We still have the pneumothorax though. So what do we do for a pneumothorax? We put a chest tube in and re-expand the lung. What do we do for a hemothorax? Well, a hemothorax, as it gets bigger and bigger, we want to drain it because it's stopping the lung from expanding. So we'll put a chest tube in and drain the blood. We'll monitor the output of the chest tube of how much drainage there is from the pleural space. Same thing for a pleural effusion. What can we do? We can put a chest tube in, or we can aspirate it with a thoracentesis, right? Put a needle in when we're talking about a thoracentesis, and we drain the pleural effusion. Okay, so let's look at the risk factors for pneumothorax, okay? Just a collapsed lung. Typically just on one side. I mean, you can have a collapsed lung on both sides. That's not good. right? Because now you can't ventilate since both lungs are collapsed. Most of us with healthy lungs can continue to breathe and ventilate with one lung, at least temporarily. Okay? So blunt chest trauma. So a major injury to the chest. Remember, the the lungs are like balloons, right? They're attached to the inner chest wall. So a significant chest trauma can collapse a lung and lead to a pneumothorax. A penetrating chest wound, so say a knife wound to a chest that punctures through the pleura, is going to cause the lung to separate from the pleura, leading to a pneumothorax. What about someone who already has a pneumothorax or is getting a chest tube? Well, we could potentially collapse the lung while putting in the chest tube, right? So say we're putting in a chest tube for a pleural effusion to drain it, and by accident we hit the lung. Well, we can cause it to collapse. Okay. Patients with COPD. So patients with COPD have scarring to their lungs, and they develop almost like blebs and blisters on the outer part of their lung, and some of those can pop. Okay. So they have very abnormal lungs because of the alveolar destruction, and they get these blebs. And if a bleb were to break in someone with COPD, the whole lung collapses, causing a pneumothorax. And the last one, and probably one of the most common, is a young person, a young, tall person. And it's called a spontaneous pneumothorax, where they're just walking along and suddenly, boom, their lung collapses. So why is that? Well, a tall, thin person typically has tall lungs, right? They have a higher level between their upper lung and their lower lung, and because the lung is spread out more, it has the potential to collapse spontaneously. Okay, because the pressures are slightly different in those patients. So if you were to think of someone just walking along and their lung collapses, it's typically a tall, young person that it happens to. Okay, and they come in and say, I have terrible chest pain and I'm short of breath. And we do a chest x-ray and we see that their lung has collapsed with no injury at all. Okay. Now, the image on the right is showing you a pleural effusion. Okay, that's not a pneumothorax. A pleural effusion is a collection of fluid in the pleural space. Okay, keep them separate. If you have a pneumothorax, it does not mean you have a pleural effusion at all. It means you have air in the pleural space. Okay, I'm gonna repeat myself here for simplicity. A pneumothorax is just a collapsed lung. There's no image of it here, just a collapsed lung. A tension pneumothorax, it's a collapsed lung that has air in the pleural space, just like a pneumothorax, but now it's air under pressure, right? And it's going to move everything, it's going to shift everything over to the other side of the chest cavity. Okay, that's a tension pneumothorax. Pleural effusion, collection of fluid in the pleural space. Okay, so, and what's a hemothorax? Well, it's a collection of blood in the pleural space. Okay, so now let's talk about a flail segment. What's a flail segment? It, usually from an accident, it is rib fractures, so 2 rib fractures at each rib and 2 or greater ribs. Okay, so now you have a segment that's not attached to the rest of the chest wall. So when that person takes a breath in, well, there's negative pressure in the chest. And as the chest is expanding, that segment's going to go inwards, as you can see in the image in the bottom there. When they breathe out, that segment's not attached to the chest wall, and there's positive pressure during expiration, that segment's going to bulge out because it's completely independent from the rest of the chest wall. Okay? What are you going to get with a simple pneumothorax? Well, person's going to come in with chest pain on that side and shortness of breath. It hurts to take a breath. Okay, so we examine them. They have hyperresonant lung sound on that side. There's no lung there anymore. There's just air. So it's going to be hyperresonant when we percuss it. When we listen to it, it's going to be absent breath sounds on that side. Okay, that's a pneumothorax. Tension pneumothorax. It's going to have the same findings. When we percuss, it's going to have hyperresonant lung sounds on that side. When we listen, there's going to be absent breath sounds. What else is there though? It's now a tension pneumothorax. Everything has shifted over to the other side because of the high pressure. So now you have tracheal deviation to the unaffected side. You have distended neck veins because the blood can't get back into the thoracic cavity. You have tachycardia. The heart's trying to maintain cardiac output, but there's no blood coming back to the chest. So they're hypotensive because the blood's not getting back to the right side of the heart, so it can't get to the left side of the heart. Okay, so all of the signs and symptoms will make sense if you understand what's happening. Okay, what's going to happen with a flail segment? Well, if it's a large flail segment, the person's not going to be able to ventilate properly because every time they go to take a big breath, part of their chest wall goes inwards. So these patients may need mechanical ventilation because they're not able to expand their lungs well anymore because there's a large chunk of the chest wall that's going inwards during inspiration. Okay, what's subcutaneous emphysema? Well, that can happen with any pneumothorax, and what it is the air that's in the pleural space has tracked into the tissue, and when we touch the tissue of the skin, in the area in the chest that has the pneumothorax, we can feel almost like Rice Krispies under the skin, and that's air that's in the tissue. Okay, so keep them all separate. They're all actually separate conditions. Okay, again, we're going to keep them separate. In pneumothorax, what do we want to do? We want to re-expand the lung. Okay, how are we going to do that? If it's a simple pneumothorax, we're going to put in a chest tube. And we're going to attach the chest tube to the underwater chambers, right? Below the level of the bed and upright. And you can see the chamber at the bottom right there. Okay, and you can see the chest tube coming from the chest in the upper right. So we're going to, so in pneumothorax, what are they going to have? Hyperresonant lung sounds, hyperresonance to percussion, decreased air entry on the affected side. Okay, that's a pneumothorax. A hemothorax, a collection of blood in the pleural space. What do we want to do? We want to put a chest tube in to drain the hemothorax. Okay, and we're going to monitor how much blood is coming out of the chest tube. Okay, so that's the whole intention of a hemothorax, is to drain it. A pleural effusion, collection of fluid in the pleural cavity, in the pleural space. What can we do? We can drain it, whether it's with a thoracentesis, which is just a needle, or with a chest tube, which is more invasive, but we can drain large pleural effusions. Okay, patients often need some kind of sedation, such as a benzodiazepine, or an opioid analgesic, such as fentanyl or morphine, to decrease the pain. Okay, with these procedures, whether it's a chest tube, definitely with a chest tube or thoracentesis, we also freeze the tissue, right? We give it a really good local anesthetic. Okay. Okay. This is probably repetitious, but that's how you remember things. So pleural effusion, okay, that's a collection of fluid in the pleural space from any cause. And gradually, as the pleural effusion gets bigger and bigger and bigger, as you know, we're looking at a left pleural effusion here, it's going to squash the lung. It's going to move that lung out of the way. So it's going to make it hard to breathe. And that's why we'll either do a thoracentesis, where the person's leaning on a table and we're freezing their back and putting a needle into the pleural space to drain the fluid, or we could drain it with a chest tube. Okay. Now, how does that differ from pulmonary edema? Well, pulmonary edema is typically from congestive heart failure, so from left ventricular heart failure, and it's backing up into the lungs. Well, that definitely doesn't need a chest tube or thoracentesis because all the fluid is within the lung, right? It's not in the pleural space. So how do we treat that? Well, we can treat pulmonary edema with diuretics to drain fluid out of the patient's system. We can treat it with medications that can help the heart pump better so it's not backing up into the lungs as much, right? And there's many medications to do that. Okay. Pulmonary embolus, that's where we're looking at a blood clot that travels to the lung and blocks one of the pulmonary vessels in the lung and damages the lung. Okay, so they're all very different conditions, and they're often not associated with each other. So just know them in isolation of each other. Okay. Okay, so let's do these questions together at the end of the chapter. Number 1, so this is the chapter on pneumothorax and flail chest, by the way. A nurse is assessing a client following a gunshot wound to the chest. For which of the following findings should the nurse monitor to detect a pneumothorax? Okay, pneumothorax, collapsed lung. Okay, now, if it's a simple pneumothorax, it's just a collapsed lung. If it's a tension pneumothorax, it's a lung that's collapsed, but now the pleural space has high pressure in it, and it's going to cause those other symptoms: distended neck veins, tachycardia, hypotension, tracheal deviation. Okay? Okay, let's look at the answers. Tachypnea, absolutely. If you have a collapsed lung of any kind, you're going to be breathing faster to try and maintain oxygenation. Tracheal deviation. So here's where it gets confusing because they didn't tell you if it's a simple or a tension pneumothorax. Let's just assume it could be either one of them. Tracheal deviation, absolutely. Okay, so if there's a tension pneumothorax, which by the way is quite uncommon. Tension pneumothorax is uncommon. I don't want you to think it happens all the time compared to a simple pneumothorax. Anyways, tension pneumothorax, you got deviation of the trachea to the unaffected side, right? To the other side of the chest. Bradycardia, definitely not. You're going to be tachycardic. Decreased use of accessory muscle use. No, you might be using your accessory muscles because one of your lungs has fully collapsed and you need to continue ventilating, breathing, right? So no, D is not correct. Pleuritic pain, absolutely. This lung has separated away from the pleura, which is exquisitely sensitive with lots of nerve endings. You are going to have a lot of pain on the side of the pneumothorax. So the answer is A, B, and E. 2. A nurse is assisting the provider to care for a client who has developed a spontaneous pneumothorax. Which of the following actions should the nurse perform first? Okay, spontaneous pneumothorax is typically a tall, young person, and their lung just suddenly separates from the pleura, and they get a pneumothorax. Okay, which of the following actions should the nurse perform first? Assess the client's pain. It's going to be A, B, and C coming into here. So assessment of pain isn't number 1. It's important, but it's not going to be as important as airway, breathing, circulation, right? Obtain a large bore IV for decompression. Okay, so here's where it starts to get confusing in ATI again. If it's just a simple pneumothorax, meaning the lung has just collapsed, we're going to re-expand it with a chest tube. because typically it's not a tension pneumothorax. In these questions, they're just assuming that they're all the same. So they're calling a spontaneous pneumothorax has now been complicated into a tension pneumothorax, which often isn't the case. But let's just assume that they're asking for any pneumothorax. So B would be the answer. You want to put a needle through the chest wall to take the pressure out. Okay, so B would be the answer. Administer lorazepam. No, that's just a sedative. Don't need it right now. That's not the first thing you would do. Prepare for chest tube insertion. Well, that would actually be the answer I would choose, because most spontaneous pneumothoraxes are not under pressure, and we would just tell the patient that we need to re-expand their lung and put in a chest tube. With these questions, they're just assuming that it could be any kind of pneumothorax, tension or just a simple pneumothorax. So the answer would be B, because you would need to decompress the pressure, take the pressure out of the chest before putting in a formal chest tube. Okay, so B. 3. A nurse is reviewing discharge instructions for a client who has COPD and experienced a pneumothorax. Which of the following statements should the nurse include? So COPDers have those blebs and blisters on the surface of their lungs, and if they pop, they get a pneumothorax. Okay, which of the following statements should the nurse include? Notify the provider if you experience weakness. Okay, that's pretty non-specific. You should be able to return to work in 1 week. Not necessarily, right? If your pneumothorax isn't re-expanding very well, you may not be able to return to work in a week. C, you need to wear a mask when in crowded areas. No, there's nothing infectious going on here, right? You have a collapsed lung. Notify your provider if you experience a productive cough. This one's not really that clear, but so the person has a pneumothorax, a collapsed lung. So if they're being treated for a collapsed lung, there is a risk of the lung getting infected since it's been collapsed. So you would notify someone if you're starting to cough up productive phlegm, because that can be a sign of infection. Okay, I'm not a big fan of this question at all. Okay. Number 4, a nurse in the emergency department is assessing a client who has sustained multiple rib fractures and has a flail chest. Okay, so a flail chest means that there's a segment of the chest wall that is completely not attached to the rest of the chest wall. Okay, so 2 fractures in each rib and more than 2 ribs. So 2 or greater ribs, sorry. Okay, so which of the following findings should the nurse expect? Bradycardia. No, they wouldn't be bradycardic, right? Even just for the sake of discussion, they have pain, they'd be tachycardic. They wouldn't be bradycardic. Cyanosis, that is totally possible because they're having problems expanding that lung because there's a loose segment of chest wall that's sucking inwards, right? Paradoxical breathing. So they could be cyanotic. Hypotension, they could be hypotensive, right? So they could be hypotensive because possibly the lung behind the flail segment could be collapsed. They may have a tension pneumothorax behind that flail chest. So they could be hypotensive. Shortness of breath or dyspnea, absolutely. They could be short of breath because they're having difficulties ventilating. Paradoxical chest movement, absolutely, because of that loose flail chest segment. Okay, so B, C, D, and E. The only one I don't like is C, hypotension, because the loose segment in it by itself is not making you hypotensive, right? That's just a loose segment of the chest wall. It's definitely affecting your breathing, but what's making you hypotensive? So I find that just an unfair, they likely will be hypotensive because they could have a tension pneumothorax behind the flail chest, but you'd have to infer that by the question, and I don't really find that one to be clear. Okay, so let's move on and talk about respiratory failure. from an assortment of causes. So respiratory failure just means I either can't ventilate or I can't oxygenate my blood, right? So it could be a problem with the chest wall, it could be a problem with the trachea, it could be a problem with the bronchial tubes, it could be a problem with the alveoli, all over the place. It just means that the respiratory system is not able to continue oxygenating the blood and also to clear the CO2 from the bloodstream. Okay, so acute respiratory failure, as I mentioned before, is I have difficulty ventilating my lungs. So that's the movement of the chest wall and with the lungs moving with the chest wall. So something is happening where I just can't ventilate. So for example, that could be severe asthma or severe COPD where the bronchial tubes are filled with mucus and they just can't get the air to the alveoli. Or there's something wrong with the chest wall. They have Guillain-Barré syndrome. They have myasthenia gravis. They have something that's stopping them from the ventilation process, right? And ventilation just means getting the air from your mouth to the alveoli. And that can cause respiratory failure. Okay, a flail chest would be an example of inability to ventilate. What about inability to oxygenate? Okay. What about congestive heart failure leading to pulmonary edema? So now you have fluid all in your lungs. Okay. How are you going to get the oxygen from the alveoli to the capillaries? That's an inability to oxygenate the blood. Okay. So you can see that basically any disease that interferes with ventilation or oxygenation, meaning diffusion of gases across the alveoli, can lead to acute respiratory failure. Okay, so if you were to ask me, is asthma a problem of ventilation or a problem of diffusion of gases across the alveoli? It's a problem with ventilation, right? It's bronchoconstriction, and you can't get the air to the alveoli. Okay, is a pneumothorax a problem with ventilation or a problem with diffusion? Well, it's a problem with ventilation because you can't get the lung to expand, so you can't ventilate it, right? And it's also a problem with diffusion because the whole lung has completely collapsed. Okay, so we'll come back to that. So it's basically many respiratory diseases can result in acute respiratory failure, needing intubation and ventilation. Acute respiratory distress syndrome is a condition where, remember, the capillaries in your lungs become very leaky, usually from a systemic disease, whether it's burns, pancreatitis, any severe illness that causes a lot of inflammation can cause the capillary beds in the lungs to vasodilate and become leaky. And now when they're leaky, they're leaking fluid into the lungs, and patients are developing pulmonary edema. So they get stiff lungs. It's really hard to take a breath in, okay, with acute respiratory distress syndrome. So someone can come in with a completely separate illness, and they can develop ARDS because of that severe inflammation that they have. Okay, so they have difficulty ventilating, they can't oxygenate because of all the fluid that's in their lungs, and they may end up on a ventilator. Okay. Severe acute respiratory syndrome, SARS, is a virus that in the early 2000s that came through, and it led to acute respiratory distress syndrome, right? So I don't think we need to spend too much time on that. That was a particular virus that was causing this respiratory distress syndrome. I mean, if we're talking about something more recent, COVID, COVID can get into your lungs and cause a severe inflammatory response leading to ARDS, acute respiratory distress syndrome, where your lung is filling with fluid from all the inflammation, and you end up on a ventilator. Okay, and that's how many patients have died from COVID due to ARDS. So in your book, you're going to see that acute respiratory failure has actually been separated into ventilation diseases and oxygenation diseases. So failure of ventilation or failure of oxygenation. So let's just look at a couple. COPD. Well, COPD, if you have a lot of chronic bronchitis and mucus in your airways, you can't get the air to the alveoli. So it's a ventilation issue. Now, it could be an oxygenation issue as well because you have alveolar destruction. So in fact, COPD is a mixture of a ventilation problem and an oxygenation problem. Okay, let's look at flail chest. Well, a flail chest is difficulty ventilating because part of your chest is loose. It's a separate segment, so you can't ventilate properly, right? What about asthma? Well, asthma is in the bronchial tubes, right? Severe narrowing of the bronchial tubes leading to a ventilation problem. Let's look at a couple of oxygenation issues. Pneumonia. Well, pneumonia is fluid and pus in the alveoli. So there's no problem with the ventilation initially. It's all about I can't get the air across my alveoli to get into the bloodstream. I can't get the oxygen there. So it's an oxygenation problem. What about pulmonary edema? Well, pulmonary edema is an oxygenation issue. I can't get the oxygen from my alveoli into my bloodstream. Okay, so keep the two separate. There's the ventilation, and then there's the oxygenation that occurs at the alveoli. Okay, and sometimes there's a mixture of both of them that are occurring. Okay, so what will someone with acute respiratory failure look like from any cause? Well, let's just choose a cause. How about severe pneumonia on both sides of your lungs? So the alveoli are just filling with fluid and pus on both lungs. You're going to be short of breath. You're going to be cyanotic, so reduced O2 saturation. You're going to be hypoxemic, right? Again, reduced oxygen saturation in the blood. You're going to be building up carbon dioxide in your blood, okay? Tachycardia, yeah, the heart's going to be pumping fast because it's low on oxygen, so it's beating faster and faster to try and at least pump as much oxygenated blood out as possible. Confusion because you're hypoxic, right? Agitation and restlessness, yeah, your brain is getting really nervous. You're hypoxic. Adventitious breath sounds, so basically any extra sounds in your lungs. Sure, you could have wheezing with asthma. You could have crackles and crepitations with pneumonia. You could have crepitations with pulmonary edema, with fluid building up in both lungs. So it just depends on the condition. Okay. ARDS, just think of it as I have fluid leaking out all in my lungs from some kind of systemic inflammatory condition. Okay, so am I going to be short of breath? Dyspneic, yes. I have fluid leaking out all in my lungs, pulmonary edema. Notice they say it's not from the heart, non-cardiogenic, right? Because it could have happened from any other illness, such as burns or pancreatitis, or, okay? Reduced lung compliance, yeah, the lungs are filled with fluid, so they're stiff, okay? Because there's fluid leaking out into the lungs on both sides, there's going to be patchy infiltrates, meaning when we look at chest x-ray, there's going to be patches of fluid that we're going to start to see on the chest x-ray. Hypoxemia, for sure, right? the lungs are filling with fluid, so the oxygen, the capillaries can't um, receive oxygen. Confusion is just from hypoxemia. Adventitious breath sounds, so the crepitations and crackles because of all the lungs that are, of all the fluid that's filling the lungs. So what can we do if someone's in respiratory failure with diagnostics? Well, a chest x-ray we often see, whether it's bilateral pneumonia or ARDS, and we see fluid filling the lung spaces. An ECG, that's really just to help us look at the heart rate, the rhythm of the heart. Is it a sinus tachycardia? Okay. Sometimes it helps us determine if the person's had a heart attack, a STEMI or an NSTEMI. And that might be a reason why they have fluid backing up into their lungs and causing pulmonary edema. Right? Arterial blood gases can be very useful because they're going to tell us what's the pH of this in the blood, what's the PaO2, what's the O2 sat, and what's the CO2 level. Okay, so it just gives us lots of information about what's going on with oxygenation and the CO2 in the blood. Okay, so say someone comes in respiratory failure and we just don't know the cause. They're having a lot of difficulty breathing. They're short of breath. They're sweaty. Their heart is racing. They're breathing at 40 per minute. They can barely talk to us, and we want to treat them. Okay. Do we need to know the cause right at the beginning? No. It could be pulmonary edema. It could be a huge pneumonia. It could be a pneumothorax. It could be a massive pulmonary embolus. It could be a whole bunch of things. Okay. But what we need to focus on first is airway, breathing, circulation. Okay. So airway. Are they able to get air from their mouth to their lungs? Okay. So if there's an obstruction, say we hear wheezing, or we think they may have choked on something, okay? We need to open up the airway somehow. Okay, say they have massive swelling in their mouth from an abscess or from burns, and they have so much edema that we need to secure their airway with an endotracheal tube. Okay, once we're happy with airway and we think the airway is clear, okay, we can go on to breathing. What's breathing? Well, breathing is actually the lungs, right? So can we hear lung sounds on both sides? Are they clear on both sides? Or do they have reduced air entry of one lung compared to the other lung? If there's reduced air entry, what could that be from? Could it be from a pneumothorax because there's no air going into that side? Could it be from a massive pneumonia and there's no air going into that side? Okay, so so we assess breathing by listening to the lungs and also by looking at their arterial blood gases, their O2 sat. Okay, we can assess breathing. So airway is getting the air to the lungs. Breathing is let's listen to the lungs and assess the lungs and see if there's anything that's occurring in the lungs that we can treat. Okay. Circulation is the cardiovascular status. What's the heart rate? What's the blood pressure? What's the capillary refill? All of those things in terms of the vascular system. Okay. So if it's an issue with airway and breathing, okay, let's see if we can get their oxygenation up. Let's put a nasal cannula on them. Let's put an oxygen mask on them. Let's put a non-rebreather on them. So we can just escalate the amount of oxygen that we want to deliver. And if that's not working, we may need to go to intubation and mechanical ventilation. Okay. Now D and E, We won't spend too much time on it here, but D stands for disability, which is a neurological status, a neurological exam. Okay. Are they talking? What's their Glasgow Coma scale? Can they move their arms? Can they move their legs? And E is environment and exposure. So we typically expose the whole patient to see if there's anything that we need to examine um, after we've done our ABCs, right? The environment reminds us not to keep them in a cold room. They're going to get hypothermic, and that can cause a lot of problems in terms of treatment. Okay, so so that's where the A, B, C, D, and E comes from. Okay, and the whole idea is I need to maintain oxygenation of this patient, even if it means intubating and ventilating. The C, I need to maintain blood pressure and perfusion of all the critical organs, such as the heart, the brain, the kidneys. So if someone's hypotensive, we need to address that. If they're hypotensive because they're dehydrated, we'll give them fluids, such as normal saline or Ringer's lactate. If they're hypotensive because they're bleeding severely from somewhere, we're going to give them blood to replace um, the blood that they're losing. Okay. Okay, so let's just talk about some of these drugs. A lot of these drugs that you're looking at here is when we're looking to sedate someone and intubate them. So benzodiazepines, well, they can actually shut down someone's breathing. So someone might be really anxious while they're gasping for air and short of breath. So we would be careful not to give them too much benzodiazepines unless we've made the decision that, okay, let's put them to sleep and intubate them. And then, okay, let's use some benzodiazepines to relax them, okay, and to sedate them. A very powerful sedative is actually propofol. That is going to, we often use that to sedate someone and intubate them, okay? Because you really have to be asleep for us to intubate you. Um, no one is going to tolerate a tube going through their vocal cords if they're awake. They need to be um, they need to be sedated. Okay. Now, on top of being sedated for a procedure such as endotracheal intubation, you need pain medication such as fentanyl or morphine. Why? Very painful condition. A tube going to the back of your throat is going to cause the gag reflex. A tube going through your vocal cords can be very painful, and then into your trachea. So we often give them benzodiazepines and IV opioid analgesics before intubating. Okay? So that's where those drugs come in. Corticosteroids. Well, inflammatory conditions, right? So someone is failing because they have severe asthma or severe COPD and they can't maintain ventilation or oxygenation. Well, let's see if we can get some of the inflammation out of their lungs with one of the corticosteroids. Methylprednisolone is IV. Dexamethasone can be IV or oral. Okay, so those are just steroidal anti-inflammatory drugs. The neuromuscular blocking agent would come in when we want to intubate someone, right? We want to paralyze the muscles in their neck, in their chest, to make our view very good while we're trying to get this tube into their lungs to then put them on a ventilator. So we use neuromuscular blocking agents to help us relax and paralyze all the skeletal muscles. Okay? And then, of course, antibiotics. Well, it just depends on what the condition is. If it's a pneumonia, absolutely, we're going to start IV antibiotics. So if someone went into respiratory failure because of a pneumonia, we're going to start IV antibiotics. If they went into respiratory failure because of a flailed chest, well, we're not going to start antibiotics, right? If they went in because of pulmonary edema from left heart failure, that doesn't need antibiotics. So it just depends on the condition. If it's an infectious condition, Sure, we'll start antibiotics. Okay. Okay, so let's do the questions at the end of the chapter. So number one, a nurse in the emergency department is assessing a client who is in a motor vehicle accident. Okay. Findings include absent breath sounds on the left side, left lower lung, with shortness of breath. Okay, so you have absent breath sounds and you have shortness of breath. Okay. Blood pressure looks fine, 118 on 68. Heart rate is fast at 124. Respirations are fast at 38. The temperature is elevated, so 101.4. And the oxygen saturation is reduced, 92%. Okay, 95 to 100 is normal. Which of the following actions should the nurse take first? Okay, so this person is tachycardic and breathing fast following a car accident. So I'm thinking of some kind of traumatic event has occurred in the chest. Could be rib fractures, could be a flailed chest, could be a pneumothorax. So there's a number of causes that could be occurring, giving this person their symptoms and signs. So I'm going to revert back to my ABCs. What's the most important thing? The person needs to have oxygenation. And if their O2 sat is low, this isn't terribly low, but just for the purposes of this question, I'm looking to get a normal O2 saturation. So I need to get their O2 sat up to 95%. So they're going to need oxygen first. So obtain a chest x-ray? No, that's going to be later. Okay, not much later, but it's going to be later. Prepare for chest tube insertion? Well, I don't even know if they have a pneumothorax or a hemothorax, so I'm not going to prepare for that yet. Administer oxygen via high flow mask. Yes, I want to get their oxygen up to normal before I do anything else. Initiate IV access. We will do that, but does it have to be the first thing? No, their blood pressure is fine. Now their heart is definitely racing, so it could be bleeding from somewhere. But the first thing is airway, right? Airway, breathing, oxygenation. So it's going to be C. 2, a nurse is orientating a newly licensed nurse on the purpose of administering vecuronium to a client who has acute respiratory distress syndrome. Which of the following statements by the newly licensed nurse indicates understanding of the teaching? Okay, so if we're going to inject vecuronium, which is a complete muscle paralytic, we're definitely not doing it if the patient's awake, right? So it sounds like we're preparing to intubate this person because that's why we'd want to paralyze them. So they need to be asleep with sedatives such as benzodiazepines or propofol. They need analgesics such as IV morphine or IV fentanyl because this is going to hurt. And then we can give vecuronium. Okay, so this medication is given to treat infections. No, it's a paralytic. This medication is given to facilitate ventilation. No, it's a paralytic, right? So I'm really hoping that's not the answer here, and it is the answer. So it's not to facilitate ventilation, it's to allow us to open up. It allows for muscle paralysis, so we can actually you get the endotracheal tube into the trachea and ventilate the patient with a ventilator. Okay, so this medication is given to facilitate ventilation. Well, it's used to paralyze the muscles so we can get an endotracheal tube in. Okay, this medication is given to decrease inflammation. No, that would be something like a glucocorticoid. This medication is given to reduce anxiety. No, that would be something like propofol or more generally benzodiazepines would be used to decrease anxiety. So I guess I would have to go back and stare at B and say, well, the medication is given to facilitate ventilation. If the answer said this medication is given to facilitate intubation, well, I would definitely go for B. But I don't have a choice here because that's the only other semi-close answer. So it's going to be B. I wanted to mention one more aspect to question number 2. Sometimes if someone's on a ventilator and they're really fighting the ventilator in terms of they're taking breaths when the ventilator's trying to push air into their lungs, and there's just all kinds of, it's just asynchronous. So, and sometimes we just want to paralyze the patient and let the ventilator do all the work. Then we will put them on vecuronium and keep them on vecuronium potentially for a day or two to completely paralyze them. Don't forget, if you're on a paralysis, you have to be completely sedated and have pain medication because all this drug's doing is paralyzing your muscles. So in that sense, it would help facilitate ventilation while they're on the ventilator. Okay, so I thought about it a bit more, and B is the only good or decent answer there. Okay, 3. A nurse is reviewing the health records of 5 clients. Which of the following clients are at risk of developing acute respiratory distress syndrome? So acute respiratory distress is when the vessels in your lungs are leaky and they're leaking fluids into the lungs all over and you're getting pulmonary edema. Okay? So who could develop ARDS? So a client who experienced a near drowning incident. Absolutely. So if they've had fluid gone into their lungs and it's caused a lot of inflammation in the lung tissue that's caused leaky vessels, they could develop ARDS. A client following coronary artery bypass graft. I mean, it is possible to develop ARDS because what have they had done? They've had their chest opened like a clamshell, and that's a form of trauma, really. So, could they develop ARDS and leaky blood vessels in their lungs, leading to stiff lungs? Sure. Okay. A client who has a hemoglobin of 15.1, no, nothing's happening there. There's been no trauma. There's no systemic inflammation, so no. A client who has dysphagia. Well, dysphagia is really just difficulty swallowing, right? That's what the term dysphagia means. So now we're into this assuming again. So if you have dysphagia, could you get aspiration? Yes, you get aspiration. Could you get pneumonia from aspiration? Yes, it's possible. And could you get ARDS, which is inflammation occurring, all in the lungs, causing vasodilation from a pneumonia? Yes, but there's a lot of assuming there. So that's probably going to be an answer, but that's a bit of a stretch. A client who experienced acute drug toxicity. So someone who's experienced acute drug toxicity could say they were unconscious and say they weren't ventilating well. Could they develop ARDS from the drug toxicity? Sure, it's possible. Say the drug toxicity was in the lungs itself. It caused inflammation of the lungs, and that caused leaky vessels in the lungs, causing ARDS. So that's possible. So it's probably going to be A, B, D, and E, but D is a real stretch because there's a lot of assumptions going on there. Okay. 4. A nurse is planning care for a client who has severe acute respiratory distress syndrome. Okay, SARS, so that's caused by a viral infection in the early 2000s when SARS came through. Which of the following actions should the nurse include? Antibiotics? No, because it's a viral infection that caused SARS, right? Provide supplemental oxygen? Definitely. If you have severe acute respiratory distress syndrome, you're likely hypoxic. So providing oxygen. Administering antiviral medications. Well, SARS was a virus, but there was really no effective antiviral for it. I think this is a bit of an unfair question too, because how could you know that from years later? So no, C is wrong. Administer bronchodilators. Yeah, if you have a viral infection of your lungs and bronchial tubes, could you be wheezing? Absolutely, right? So bronchodilators could be used. Maintain ventilatory support. Yes, some of these patients had to be put on a ventilator, um, and they needed um, support of their ventilation. Okay, so A's wrong, B's right, um, D's right, and E's right. Okay. Last question. A nurse is caring for a client who is receiving vecuronium during mechanical ventilation. Okay. Which of the following medications should the nurse anticipate administering with this medication? So you definitely need, this person definitely needs to be sedated, right? So some form of sedation. They cannot wake up and be paralyzed. That would be horrifying. Um, so so midazolam is a benzodiazepine. It's definitely going to be part of the answer. Um, Furosemide is to clear fluids out of the lungs in pulmonary edema. That's not mentioned here. So you don't need that to use vecuronium. Famotidine is an H2 blocker for for GERD. Um, that doesn't need to be used for mechanical ventilation necessarily with vecuronium. Dexamethasone is an anti-inflammatory corticosteroid. That doesn't necessarily have to be used. But fentanyl. So fentanyl is an analgesic, right? You have a tube down your throat. You're on a ventilator. That's going to hurt a lot. So fentanyl for the pain, a benzodiazepine such as midazolam for the sedation while giving vecuronium. Okay. Okay, so let's talk a bit about a couple of other disorders, and then we're done this module. I know it's on the long side, but the questions at the end of ATI I've tried to help you out with. Not that I'm a fan of all of them, but tried to help you work through them. So we'll talk about obstructive sleep apnea here, epistaxis, fractures of the nose, pulmonary hypertension. Okay, so let's move on to the next slide. Okay, so obstructive sleep apnea is uh, basically what it says. So while someone is sleeping, the muscles of the tongue and the back of the throat become very relaxed, which is normal, but then they occlude the airway and they frequently have snoring. So snoring's not the issue. Obstruction of the airway is the issue, and they get apnea, right? Periods where they're not breathing. So that's important because if you have periods of apnea, then you're going to have hypoxia through the night or hypoxemia because there's no air getting to the alveoli for periods of time. And then you're going to have hypoxemia because the blood that's coming into the lungs from the right ventricle aren't being oxygenated. So you're getting deoxygenated blood to your left ventricle and then to the systemic circulation, hypoxemia. And that's a problem, right? Because the body doesn't want to be hypoxemic. So what happens is that triggers the brain to wake up when it detects hypoxemia, and you get very poor sleep because you have periods of sleep apnea, and then the brain wakes you up. Okay, then you fall back asleep, you become hypoxemic, the brain wakes you up. So often patients have very poor sleep because of very interrupted sleep cycles. So what does that cause? Well, decreased daytime memory, decreased concentration, decreased making decisions, falling asleep at the wheel. So a driver or a truck driver could fall asleep at the wheel, right? Because of very, very poor sleep from the sleep apnea. So just imagine you go through your whole night and you have, say, 100 periods of sleep apnea, and your brain has woken you up 100 times because it's detecting hypoxemia. Okay. What are the risk factors? Well, being obese because there's more tissue to potentially occlude the airway. Males have higher chances of developing sleep apnea. Alcohol, because it has sedative qualities, so drinking alcohol at night typically makes people snore and cause sleep apnea. Sedatives, such as benzodiazepines, are a risk factor for having sleep apnea. Okay, so if we see people with sleep apnea that are consuming alcohol, on sedatives, we try to remove those to see if the sleep apnea improves. We also advise them to lose weight, okay, because that can improve sleep apnea. So, so often it's associated with snoring because you can imagine as the airway is occluding, um, you're starting to snore, right? Uh, but really, the big thing is the episodes of apnea. So 10 seconds or longer, and a minimum of 5 episodes per hour. How do we diagnose that? Sending someone to a sleep lab overnight, and they get monitored for periods of apnea, and they have an O2 sat monitor on to see if they're deoxygenating. They're becoming hypoxemic. Okay. So lots of people have sleep apnea that just haven't been diagnosed yet. And they have daytime sleepiness, memory loss, inability to make decisions. Okay. So what's the main treatment for someone diagnosed with sleep apnea? Well, pressurize the airway during the night. So pressurize it and keep the muscles out of the way from collapsing. And that's with CPAP, continuous positive airway pressure. Positioning, so instead of someone lying on their back, where everything's going to collapse to the back, like in the image here, lying on the side. Putting pillows on the side to stop them from turning over. Weight loss, to reduce some of the tissue that's going to collapse. Okay. So those are the main treatments, and CPAP I would say is the main treatment for this, along with weight loss and removing sedatives and alcohol. Okay, so what's epistaxis? A nosebleed, right? So what can cause a nosebleed? Well, a lot of air goes through your nose, right? So dry mucous membranes, say in winter climates, where there's a lot of dry air, or say you're receiving oxygen therapy, that can dry out your nose, and it can lead to nosebleeds. Nasal steroids, they can thin the tissue in the nose and lead to recurrent epistaxis. Illicit drugs, so probably referring to cocaine here, which can irritate the nasal mucosa and cause nosebleeds. Trauma, so falling on your nose, falling on your face, can lead to epistaxis. Hypertension is a relatively uncommon cause of nosebleeds. They don't typically cause nosebleeds. You can definitely bleed more if you're very hypertensive. They're not usually a cause of nosebleeds, though. Tumors in the nose, low platelets, so thrombocytopenia, anticoagulants, whether it's aspirin or warfarin. Warfarin can make unbelievable nosebleeds where there's just a trail of blood because they just won't stop bleeding. Okay? So, what do we do for epistaxis? We get people to blow out everything in their nose to start with. It's usually a horrendous mess everywhere. Blow everything out, and then direct pressure on the nostrils, right? So we actually have clothespins, so these special clothespins, so that someone doesn't have to hold pressure for 10 minutes. We have these, they look like clothespins, and they just kind of go around the two nostrils and put pressure on them, okay? Sitting upright with head tilted forward, otherwise all the blood is pouring back in your throat. We can spray neosynephrine into the nose to vasoconstrict the blood vessels and stop them from bleeding. If we can see the bleeding vessel, we'll cauterize it with silver nitrate. Okay, that's only if we can see the bleeding. We have these balloons that we can put into the nose, and then we blow up the balloon, and it pressurizes and squashes all the nasal mucosa because we've inflated the balloon, and that often can stop the bleeding. Okay. Epistaxis can be really serious if you're on anticoagulants, as I mentioned, because they can become anemic and hypovolemic. They can really get into big trouble when on anticoagulants with a serious nosebleed. Okay, so fractures of the nose, The only part of the nose you can actually fracture is the upper part of the nose where there's a bone. The rest of the nose is actually cartilage. You can still deviate the cartilage, and then a lot of people call that a nose fracture. But if you look at the image here, the only part you can really fracture is the upper part of the nose because the rest of it's cartilage. And obviously there's pain if there's been an injury and caused a fracture of the nose, or a deviated septum is what we call the cartilage that's injured or damaged. Nosebleeds, epistaxis, significant swelling and deformity can occur. We can sometimes do x-rays to see if there's a fracture of those bones in the upper part of the nose, but we're not going to see the cartilage. Okay? Now, with severe fractures, sometimes we're concerned about that there's cerebrospinal fluid leaking out. Okay, because not far from the upper nose is the meninges and the brain, right? So you can bleed from an area called the cribriform plate, and it'll bleed clear fluid, right? And we can do a test on that leaking fluid to confirm that it's actually cerebrospinal fluid. Okay. For the most part, it's really just ice, an ice pack to the nose, elevating the head of the bed so if they're bleeding, it's not all pouring back to the back of their throat. We'll often have to pack the nose with gauze packing if it's bleeding a lot. Okay, and often people have to come back and have what's called a rhinoplasty, which is correction of that deviated septum. So most people that have a nose fracture, they don't actually have a nose fracture, they have deviated cartilage, and that can be corrected surgically and just straighten out the cartilage. Okay. Okay, so let's just spend a bit of time talking about pulmonary hypertension. So it's just what it says. In actual fact, it should say pulmonary artery hypertension. So typically what happens is there's a disease in the lungs, such as COPD, which is not only destroying the alveoli, but it's also really impacting those capillary beds around the alveoli. And as more and more of the blood vessels are damaged, then you start to get decreased flow through them, and it causes pulmonary artery hypertension. Well, what's the problem with pulmonary artery hypertension? Well, the problem is that now the poor right ventricle has to pump blood into the pulmonary artery at higher pressures. And after over years, the right ventricle starts to get strained, and it starts to fail, and you get right ventricular failure called cor pulmonale. Okay? So what can cause elevated pressures in the capillaries of the lungs? Well, let's just start with a pulmonary embolus, a blood clot into the lungs. That's going to immediately cause pulmonary artery hypertension because the artery is blocked, right? So that's going to put a big strain on the right ventricle. What about heart failure? So heart failure, say your left ventricle is failing and there's backup of fluid into the lungs. Well, there's backup of fluid in all the blood vessels of the lungs. So now the poor right ventricle is pumping against higher pressures in the pulmonary artery because the blood's not flowing well to the left side of the heart. So heart failure can do it. COPD, lung disease. Well, why lung disease? Because the alveoli and the capillaries are being destroyed, and there's fewer and fewer blood vessels to pump the blood through, so you get pulmonary artery hypertension. And idiopathic is they're typically an autoimmune disease where the pulmonary vessels, capillaries, and arteries are being attacked and destroyed, and that causes pulmonary artery hypertension. So the end result of all of these conditions is pulmonary artery hypertension, and then that causes right ventricular failure called cor pulmonale. Okay? So any of these symptoms can occur. So shortness of breath. Okay, well, shortness of breath is a very general symptom, right? So many things, as we've seen in this module, cause shortness of breath. Fatigue, why? There's less blood going to the left side of the heart. So there's less blood being pumped out, so they're tired. Okay. Hemoptysis, well, the blood vessels are being damaged and destroyed. So there's hemoptysis. I wouldn't worry too much about the symptoms of pulmonary artery hypertension. I would understand the concept of why COPD or left ventricular heart failure or why a pulmonary embolus causes pulmonary artery hypertension, which then causes cor pulmonale. Okay, I would say that's the most important part. Okay, so in terms of the treatment, well, the treatment just depends on the condition, right? So if it's COPD, well, we use bronchodilators. We may have to use home oxygen to treat the COPD. If it's idiopathic, where just the blood vessels are being destroyed by an autoimmune disease, well, sometimes there really isn't any good treatment, and we'll use oxygen because they're hypoxic. We'll use vasodilators to try and dilate the remaining blood vessels in the lungs. So it really just depends on what the underlying disease is, okay? So someone with idiopathic pulmonary hypertension, they may need a double lung transplant because the right heart can't get blood to the left side of the heart any longer. And the only treatment after they've gone through these medications is a double lung transplant. So it just depends on what's causing the underlying condition. Okay, so most of the modules are not going to be this long. Okay, these are heavy modules, so I've tried to take my time going through them. I just want you to keep in mind, keep the topics separate. What's asthma? What's COPD? What's a pneumothorax? What's a hemothorax? What's a pleural effusion? Keep them all separate, okay? These often don't combine together, okay? So, what's a rib fracture? What's a flailed chest? So it doesn't mean that if you have a flailed chest, you always have a pleural effusion or you always have a pneumothorax. So just understand the concept of each one and how it affects the respirations, okay? That's the important part of this, because sure, the questions on your exams will relate to this, but also just if you have a really good understanding of this going forward, you'll retain some of it for the NCLEX, okay? And that's what I'm trying to give you here. Just a general understanding of what a pneumothorax is, what a tension pneumothorax is, so you can answer the questions and have a good understanding of the mechanics that are happening with these diseases. Okay, so as soon as you see a question about pneumonia, okay, I know what pneumonia is. It's typically a bacterial or viral infection of the alveoli, causing a reduction in oxygen getting to the bloodstream. Okay, so keep things very straightforward in your mind, and it'll really help you going forward. Okay, so I hope this helps. Most of the modules are not going to be this long.